On behalf of the Department of General Surgery and Association of Surgeons of India, Tirunelveli City Branch, I cordially welcome you all for this nice morning. And this wonderful morning we have to start the session. So I welcome you all on behalf of the General Surgery Department, faculty members, postgraduates and all the members of the surgical family once again. And so we'll have a small introduction. I welcome Tangaya sir. So after a long time he is in our department. We are very happy, sir. You made it today. And I welcome Pandi sir. He was our retired head of the department. Now he is a professor of surgery in Mugambi Medical College. And the speaker madam, today's first topic, anatomy. Jayanti madam has come long before we came to the hall. So welcome madam on behalf of the Department of General Surgery. So the light up. So there is a small introduction. So next. As you all know, the colorectal malignancy is the second most common cause of cancer deaths and is the fourth most common cancer worldwide. So the ratio between male and female is almost equal. This is common in Western world but rare in Asia and Africa. So the lifestyle plays a very important role in the colonic malignancy. So with this small introduction, we will move on to the next topic, that is applied anatomy of colon and rectum. As I invite Jayanti madam to deliver her talk. Thank you.
Hello.
Good morning, everyone. First of all, I thank God, and I would like to thank our professor, Dr. Alex sir, for giving this opportunity to present this topic. Today, my topic is colorectal anatomy and its applied aspects. See, the large intestine that extends from the cecum in the right iliac fossa to the anus in the perineum. So it surrounds the centrally placed small intestine. Its length is shorter than small intestine. It's around 1.5 meter or 6 feet in length. Its diameter is greatest in the cecum and it is gradually decreased up to the middle of the rectum. After that, in the lower part of the rectum, it presents a dilatation that's called the ambula. Then, it has cecum and appendix, colon proper, rectum and anal canal. The colon proper consists of ascending colon, transverse colon, descending colon and sigmoid colon. When we examine the external appearance of the large intestine during surgery, it shows three important cardinal features, which are tinea coli, horstrations and appendix epiploicae. So the tinea coli, these are thick longitudinal bands which are 3 in number. So these bands are formed by the aggregation of longitudinal muscle fibers which are absent over the rectum, anal canal and also appendix. In between the thick longitudinal bands, the longitudinal muscle fibers are thinned out. The total length of the tinea coli is 4 feet in length So within the 4 feet length, the entire 6 feet length of large intestine is attached. So that produces some outward pouches, that is the hostrations or saculations. So the saculations also absent in the rectum and anal canal. Then over the outer surface, small peritoneal pockets are there which are filled with fat. So the fat-filled peritoneal pouches are named as appendix epiploicae, which are absent in the rectum and appendix, very few on the cecum and ascending colon, but more over the transverse colon and the sigmoid colon. Next. Before going to see the internal appearance, come to the microstructure. See, the wall of the colon is made up of, like small intestine, mucosa, submucosa, muscularis externa and serous layer or adventitia. The mucosa that is formed by the lining epithelium, lamina propria and muscularis mucosa or muscularis interna. Here the lining epithelium is simple columnar epithelium. It is lined by absorptive columnar cells, then goblet cells. See the empty look appearance, which are goblet cells, mucus secreting cells. Then M cells, microfold cells, which are mainly present over the lining epithelium above the lymphoid aggregations. Then in the lamina propria, there are many glands or crypts. These are tubular, long and closely packed, numerous in number. See, these glands are also lined by absorptive columnar cells, goblet cells and also neuroendocrine cells. Then here in the connective tissue, there are lymphoid aggregations also there, which are more towards the distal part of the colon. Then the muscularis mucosa, that is the smooth muscle layer, thin layer. Here the muscle fibers are arranged in the form of inner circular, outer longitudinal layers. Then the next layer is the thick connective tissue layer, that is submucosa. Here blood vessels and also nerve plexus are there, which are called submucous plexus or mesinous nerve plexus, which contain paraganglionic cells, parasympathetic ganglion cells. Then the stimulation of these nerve plexus that control the secretion of the colon. The next layer is the muscularis externa. So here the smooth muscle fibers are arranged in the form of inner circular, outer longitudinal layers. So in between these two layers there is a nerve plexus that is called myendric plexus. Then here the longitudinal muscle fibers aggregate to form the longitudinal bands. Then the outermost layer is the serous layer. Wherever the outer surface is covered by peritoneum, it is lined by serous layer. Then in non-peritoneal area, the outer layer is the adventitial layer. Now, when we examine the interior of the lumen of the colon, the colonic hostrations refers to the sides of mucosa and submucosa of the colonic wall is infolded. See, the colonic hostrations, that is the mucosal folds in the inner aspect, that partially encircle the bowel lumen, and the knowledge of the pattern of colonic hostrations and the appearance of the colonic mucosa help the clinicians to appreciate the level reached during the endoscopic procedures. Then in the cecum, the three tinea coli converge at the base of the appendix, so that give the trefoil pattern. So this is in the cecum. Then at the orifice of the appendix, it gives a spiral mucosal pattern. Then in transverse colon, the colonic hostration form a triangular appearance. So this is triangular appearance. Then in descending colon and sigmoid colon, the hostrations produce thick, short and more circular folds. Then in rectum, so this one is in the sigmoid colon. Then in the rectum, the colonic hostrations form consistent, recognizable transverse folds. And here the submucosal vessels are clearly seen and the veins are more distinct here. Next. Before going to each part, come to the development. See the primitive gut, it is developed from the enteroderm of the definitive yolk sac. the primitive gut that extends from here in the cephalic side buccopharyngeal membrane to the clavicle membrane at the caudal side, and it is divided into foregut, midgut and hindgut. This primitive gut is completely invested by splanchno-pleuric layer of lateral plate mesoderm except the proximal portion of the foregut. Then after investing this primitive gut, the two layers project to the posterior wall, that is dorsal abdominal wall, so that forming the dorsal mesentery. So this dorsal mesentery that convey the blood vessels to the particular part. So here the artery for the foregut is celiac artery, then artery for the midgut is superior mesenteric artery, then artery for the hindgut is inferior mesenteric artery. See, in general, the mucus lining epithelium, then the associated glands which are developed from the endoderm of the primitive gut. Then the surrounding splanchno-pleuric layer of mesoderm that develops the muscular coat and the other adventitial fibrous stroma and serous coat. Okay. Next. Here come to the midgut. See, the midgut initially present in the median plane. In further growth it presents a U-shaped loop. So at the apex this is the vitreointestinal duct that will disappear around the 5th week of development. Then the superior mesenteric artery is present at the axis. By this it is divided into pre-arterial segment and post-arterial segment. The post-arterial segment of the midgut loop develops the cecum and appendix, then ascending colon, proximal 2/3 of the descending colon. Then the hindgut that is divided into two parts by the attachment of the allandoic diverticulum into pre-allandoic and post-allandoic parts. The pre-allandoic part that develops the distal 1/3 of the descending transverse colon, descending colon, sigmoid colon and a part of rectum. Then the post-allandoic part that is a dilated one that is called endodermal cloaca, that is divided into two parts, ventral and dorsal part, by a mesodermal partition. This is called urorectal septum. Okay. Then the ventral part that is called the primitive urogenital sinus, later that develops the urinary bladder and also the part of urethra. The posterior part, the dorsal part, is called the primitive rectum. So that develops the rectum, remaining portion of the rectum and also upper part of the anal canal. The lower part of the anal canal is developed from the ectodermal proctodium. See, the urorectal septum that descends downwards and fuse with the clavicle membrane here. So this fusion later forming the perineal body. So by this fusion, the clavicle membrane is divided into two parts, ventrally called the primitive urogenital membrane and dorsally called the anal membrane. So the anal membrane ruptures and after that the primitive rectum communicates with the exterior. So the rupture of the place of the anal membrane representing the pectinate line in the anal canal. Next. So here the congenital anomalies of the colon are atresia or stenosis of the colon. This is due to recanalization, failure of recanalization of the colon. Then congenital megacolon, that is due to the agenesis of the congenital agenesis of the neurons in the myendric and submucosal plexus. Then common perineal outlet. See here, the urogenital tract and the alimentary tract have a common outlet. This is due to failure of the downward growth of the urorectal septum. Okay. Then rectovesical fistula. So that is also due to failure of incomplete growth of the urorectal septum. So the rectum is connected to the urethra, or the rectum is at a higher level connected to the urinary bladder. Then imperforate anus, that is due to failure of rupture of the anal membrane that leads to a condition called imperforate anus. Next. Now come to the cecum. So here it's a blind pouch in the right iliac fossa. It's 5 to 7 centimeter in length and breadth. Then superiorly it joins with the ascending colon at the ileocecal junction. Topographically it occupies a triangular area that is bounded above by the transtubercular plane. The transtubercular plane that passing in front that connects the tubercles of the iliac crest. The tubercle of the iliac crest is situated 5 centimeter just behind the anterior superior iliac spine. Then posteriorly, the transtubercular plane that passing through the lower part of the 5th lumbar vertebra. Okay, then above this is bounded by the transtubercular plane, below fold of groin on the right side, right lateral plane. Then it presents the 3 tinea coli, the tinea libera, mesocolica, omendalis, which converge at the base of the appendix. So that gives an important useful guide for identifying the appendix during surgery. Then its anterior and inferior aspect and sides posterior aspect all are covered by the peritoneum. Then posteriorly the peritoneum reflects towards the abdominal wall, and that forming many recesses around the ileocecal junction, which are superior, inferior ileocecal recesses, then posterior retrocecal peritoneal recess, which mostly contains the appendix. Then these recesses forming the potential sites of internal herniation. Then the cecum may be present in the left iliac fossa or in the umbilical region or in the subhepatic region or in the right lumbar region due to the malrotation of this midgut. Okay? Then when we examine the interior, it shows the internal ileocecal orifice and appendicular orifice. See the terminal part of the ileum that joins with the cecum through this orifice. So here there is a valve. The upper lip is horizontal here, lower lip is concave, forming a concavity upwards. Okay? And at the ends, the 2 lips unite to form a fold that is called frenulum. The ileocecal orifice is represented topographically by a point by the intersection between the transtubercular plane and right lateral plane. Then the appendicular orifice that lies 2 centimeter below and behind the ileocecal orifice. Then when we come to the relations of the cecum, it is anteriorly related with the anterior abdominal wall, then part of greater omentum and small intestinal loop. Posteriorly, it is related with iliopsoas, then iliac fascia, lateral cutaneous nerve of thigh, then also trunk of femoral nerve. Okay? Then come to the types of cecum. There are 4 main types. Fetal type. So this is fetal type, conical in shape. Here the appendix is attached to the apex. Then next type, infantile type. So here it is quadrate in outline. The appendix is attached at the in a depression at the bottom. And adult type, that is the most common type. So here the right saculations are enlarged and the appendix is attached to 2 centimeter below the ileocecal orifice. The next exaggerated type, here the right saculations are hugely enlarged. The left saculations are atrophied and the appendix is attached very close to the ileocecal orifice. Now come to the clinical anatomy. See, in the cecum and ascending colon, the thickness of the wall is less compared to other part. So risk of perforation is more common during therapeutic endoscopic procedures. And the cecum acts as a guide in operation of the intestinal obstruction. Suppose if it is empty, that indicate the obstruction is in the small intestine. Suppose it is dilated, that indicate the obstruction is in the large intestine. Then sometimes the terminal part of the ileum that invaginate into the cecum and extends towards the ascending colon. Okay, so it produces a type of intestinal obstruction. This phenomenon is known as intersusception. Next, ascending colon, that is 12 to 20 centimeter in length. It extends from the ileocecal junction and superiorly up to the right iliac colic flexure, where it turns abruptly to the left and continues with the transverse colon. And here the anterior surface and the sides are covered by peritoneum. and posterior surface is non-peritoneal. At the sides, posteriorly, this is connected to the ascending colon is connected to the posterior abdominal wall by a thin connective tissue layer that is called Toll's fascia. This fascia forming a avascular plane for dissection, for mobilization of the ascending colon when performing the right hemicolectomy. So during this procedure, there is a chance of injury to the right ureter and right gonadal vessels. See here, the right gonadal vein injury is more common than the right gonadal artery, because the right gonadal vein that terminates into the inferior vena cava at a higher level than the origin of the right gonadal artery from the aorta. Next. See the relations. See here, anteriorly, anterior abdominal wall and small intestinal loop. Posteriorly, the psoas major, iliacus muscle, then quadratus lumborum muscle, then the fascia related to this, then lumbar branches from the lumbar plexus like lateral cutaneous nerve of thigh, then trunk of femoral nerve, then iliohypogastric, ilioinguinal nerves. Okay, apart from that, right ureter, right gonadal vessels. Okay, then already told, during mobilization of the ascending colon, there is a chance of injury to the right ureter and right gonadal vessels. Next. Next come to the transverse colon. Here, it's a very long mobile part, 40 to 50 centimeter in length. It extends from the right colic flexure to the left colic flexure. In between these two, it presents a U-shaped loop. So this loop extends up to the umbilical region or just below that in erect position. Okay. Then this loop, actually it extends from the this level, that is posteriorly. Here it is related with the second part of duodenum and body of the pancreas, head and body of the pancreas. Then it descends medially and to the towards medially and downward. Then it makes a fold and it ascends upward towards left side towards the left colic flexure. Okay, so it forms a U-shaped loop. So this loop is suspended from the posterior abdominal wall by a two-layered peritoneal fold called transverse mesocolon. Okay, so the parts of transverse colon are right colic flexure, colon proper, and left colic flexure. Now come to the right colic flexure. See, this is the junction of the ascending colon and transverse colon. Okay, so this flexure is present in the right lumbar region. So here topographically this area representing by a point that is 2.5 centimeter below the transpyloric plane. So the transpyloric plane that anteriorly connects the tip of the 9th costal cartilages. Posteriorly it passing through the lower border of the first lumbar vertebra. Then it lies, this flexure is present 2.5 centimeter below the transpyloric plane, but 10 centimeter to the right side of the median plane. Okay, then its relations. See, posteriorly it is related directly to the lower part of the anterior surface of the right kidney. So here it is posteriorly, the right colic flexure is non-peritoneal. So it has a direct contact with the renal fascia here. Okay, then next. Come to the left colic flexure. Here this is the junction of the transverse colon and the descending colon. Its location is in the left hypochondrial region. Here the topographically it is represented by a point 2.5 centimeter above the transpyloric plane and 10 centimeter to the left of the median plane. Actually, compared to right colic flexure, this is present at a higher level and this one is more acute and deeply placed. And here it is anteriorly related with the left margin of the greater omentum. Then posteriorly it is related with the anterior surface of the left kidney and tail of pancreas, and it lies below the lateral end of the spleen. Okay, then here this left colic flexure is connected to the diaphragm by phrenico-colic ligament. Okay, then it is connected to the lateral end of the spleen by splenico-colic ligament. Okay, so during downward traction of the splenic flexure, care should be taken, and there is a chance of injury to the splenic capsule. So before mobilizing the splenic flexure, incised the phrenicocholic ligament. So here the transverse mesocolon, it's a peritoneal fold that suspends the transverse colon from the posterior abdominal wall. So it has two layers, and here it extends from the posterior surface of the transverse colon, then it ascends and attached to the, see the upper attached margin, the descending part of the second part of the duodenum. Okay, then here is the anterior surface of head, then here is the body of the pancreas and anterior surface of the left kidney. So that is the attachment of the transverse mesocolon. It contains transverse colon and also middle colic vessels, and the trunk of the middle colic artery is present mostly on the right side of this transverse colon. Okay, and also it contains branches of right and left colic vessels and accompanying nerves, lymph vessels and also lymph nodes. Okay. Then next, descending colon that extends from the left hypochondrial region to the left pelvic brim. It is the continuation of the descending from the left colic flexure. Okay, so it is 25 centimeter in length. Its front and sides are covered by peritoneum. Okay, then it is situated in the left hypochondrium, left lumbar region and also left iliac region. Okay, then posteriorly it is here related with the quadratus lumborum, then iliacus muscle, iliac fascia, transverse abdominis muscle. Okay, then the branches from the lumbar plexus, and also it is related with the external iliac vessels, left ureter, left gonadal vessels. Okay, here also the posterior aspect, posterolaterally, that is connected to the abdominal wall by a fascia, connective tissue layer, that's called Toll's fascia, that forms a avascular plane for mobilizing the descending colon during left hemicolectomy. Okay, then the pressure of the lower part of this descending colon over the testicular vein and external iliac vein may produce the varicocele, most commonly on the left side, and varicose veins of the lower limb. Next. The next is sigmoid colon. See, the length of the sigmoid colon is varying 40 to 80 centimeter. So it extends from the left pelvic brim, that is the lower end of the descending colon that continues with the sigmoid colon. It extends up to the front of the third sacral vertebra. Here it presents three parts. The first vertical part that descends along the left pelvic wall. Then the second part is horizontal part that extending from the left pelvic wall to the right pelvic wall. Then the oblique part extending from the right pelvic wall to the front of the third sacral vertebra. See, this sigmoid colon is suspended from the posterior abdominal wall by a that is especially from the posterior pelvic wall by the peritoneal fold called the sigmoid mesocolon. Okay, it is inverted U-shaped, inverted V-shaped, sorry. Okay, here the apex of this mesocolon is present just in front of the bifurcation of the left common iliac artery. Okay, it has one right limb and right limb and left limb. Okay, then the ureter, left ureter, that passes just behind the apex of this sigmoid mesocolon. Okay, then the left limb that is attached along the left pelvic brim, then the right limb that extends from the right sacroiliac joint to the front of the third sacral vertebra. See, the inferior mesenteric artery that passes just behind the apex, and that continues as the superior rectal artery along this right limb of the sigmoid mesocolon. Okay, the contents of sigmoid mesocolon are sigmoid colon and branches, sigmoidal branches of the inferior mesenteric artery, then accompanying veins, marginal vessels, then branches from the superior rectal vessels and accompanying lymphatics and nerves. Then here the applied valvulus. Okay, sometimes the sigmoid colon is very long with the short mesocolon, so twisting may occur that will cause the strangulation and the colon becomes distended, so that produces one type of intestinal obstruction. So this phenomenon is known as valvulus, and already we have seen the congenital megacolon or Hitch-Superens disease. Next. Then come to the rectum here. This is the lower dilated part and it is located in the pelvic cavity. It is 12 centimeter in length. Okay, actually in human it's not a straight tube because it descends along the sacrococcygeal curve. Then 2 to 3 centimeter in front of the tip of the coccyx, it just turns backward and downward and continues with the anal canal. Okay, so just above the anorectal junction, it presents a dilatation that is called ambula, and just above the anorectal junction, it presents a forward bend that is due to the pull of the puborectalis of the levator ani. Okay, so here, even though it's a part of large intestine, here the tinea coli, saculations, appendix epibloicae, all are absent. Okay, so this one begins as a continuation of the sigmoid colon just in front of S3 up to the anorectal junction. Okay, next. See, this anorectal junction that corresponds to the apex of the prostate in male. Then it presents anteroposterior curvatures and also lateral curves. The anteroposterior curves are sacral curve and perineal curve. The lateral curves are upper lateral curve, then middle lateral curve and lower lateral curve. See, the upper lateral curve that is convex to the right, that is present at the junction of S3 and S4. Then middle lateral curve that is convex to the left and present at the sacrococcygeal junction, and the lower lateral curve that is convexity towards the right and it is present at the tip of the coccyx. See, from the concavity of this lateral curves, horizontal mucosal folds extending into the lumen that forming the valves of Houston, that is rectal valves. Next. See, the rectal valves are totally 4 in number. These are here the first and third valve are constant, the second and fourth valves are inconstant. The first valve that is present at the rectosigmoid junction, okay, S3 level, 12 centimeter above the anus. Then second valve that is from the left wall and from the concavity of the upper lateral curve, okay, that is 2.5 centimeter above the third valve. Then the third valve that arising from the that is from the right wall in the concavity of the middle lateral curve. This is middle lateral curve, 5 centimeter above the anus, that lies opposite S5 vertebra. Fourth valve lies 2.5 centimeter below the third valve. See, the third valve is a very important one. Sometimes it completely encircles the lumen. Okay, it divide the rectum. By this third valve, we divide the rectum into upper segment and lower segment. Okay, the upper segment is developed from the pre-allandoid part of the hindgut. Lower segment is developed from the dorsal part of the post-allandoid part of the enterodermal cloaca. Next. Next, peritoneal relations. See, the rectum is anterior, upper 2/3 of the anterior surface is covered by peritoneum. Then at the sides, the upper 1/3 is covered by peritoneum, but the posterior surface is non-peritoneal. Okay, then in male, when we trace the peritoneum, after covering the anterior 2/3, it is reflected over the upper part of the posterior surface or base of the urinary bladder, and it also covers the superior surface of the urinary bladder, then reflects over the anterior abdominal wall. So here it forming a peritoneal pouch that is called rectovesical pouch. Okay, so the bottom of this pouch lies 7.5 centimeter above the anus. Okay, then here the rectum anteriorly related with the peritoneal part is related with the sigmoid colon and small intestinal loop. When we trace it at the sides, that forming the pararectal fossa. Then in female, after covering the anterior 2/3 of the rectum, the peritoneum is reflected over the upper part of the posterior vaginal wall, then supravaginal part of the cervix, posterior surface, then posterior surface of the body of the uterus and fundus. So here it forming a peritoneal pouch. This is called the recto-uterine pouch of Douglas. So this lies here, the bottom lies 5.5 centimeter above the anus. Okay, so here also anteriorly the peritoneal part is related with the sigmoid colon and sigmoid small intestinal loop. But the non-peritoneal part, in the female anteriorly related with the posterior vaginal wall, from which it is separated by a fascia called rectovaginal fascia. Then come to the relations of the rectum anterior relation in the male, especially. Previous slide. Okay. See here, anteriorly the peritoneal part is related with sigmoid colon and small intestinal loop, but the lower non-peritoneal part is related with the base of the urinary bladder, seminal vesicles and vas deferens, prostate, then terminal part of the ureter. Okay. Then these structures are separated from the rectum by a fascia that is called rectovesical fascia of de Nonviller. Okay, this fascia is derived from the fusion of the peritoneum of the primitive rectovesical pouch. Okay, above it is attached to the bottom of the rectovesical pouch. Below it splits to attach to the prostate and also perineal body. Okay, so this fascia is very close to the rectum. Next. Then posterior relation, see in the midline, the rectum is that is non-peritoneal. It is related with the lower three pieces of the sacrum and coccyx, then anococcygeal raphe or ligament. Then it is also related with the fascia of Voltaire. Okay, then median sacral vessels, superior rectal artery, these are present in the midline. Then just lateral to that, it is related with the sympathetic chain, then pelvic splanchnic nerve, sacral plexus. Okay. Then more laterally, posteriorly, it is related with the piriformis, coccygeus and levator muscle. Next. Then come to the, what is mesorectum? See, the lower part of the rectum is surrounded by fatty tissue that is enveloped outside by a fascia. That fascia is called mesorectal fascia. So this fascial envelope around the rectum forming the mesorectum. Here the contents are fatty tissue, then superior rectal artery and its branches, superior rectal vein and its tributaries, pararectal lymph nodes, all are present here. Okay, posteriorly this mesorectal fascia is related with the presacral fascia. Okay, so from this fascia separated by a space. So this space is called retrorectal space, that is an avascular space. Okay, so here there is the rectum is connected to the sacrum by this fascia called Voltaire's fascia. Okay, then when we trace the mesorectal fascia at the sides, it is connected to the lateral pelvic wall by two lateral rectal ligaments which contain the nervi erigenti and also the lateral median rectal vessels. Next. See here, come to the surgical anatomy. Suppose the tumor is in the rectum. During surgery, most of the rectum and its mesorectum can be removed, and remove the rectovesical fascia of the de Nonviller along with the rectum. So after separating its attachment to the prostate and also perineal body, so here preserve the ureter and the neurovascular structures on the lateral pelvic wall, and the inferior hypogastric plexus and superior hypogastric plexus are kept intact to safeguard the sexual function. Then here divide the inferior mesenteric artery close to its origin that ensure the removal of all pre-terminal lymph nodes which run along its course. Next. And here for downward mobilization of the rectum, so this is the mesorectal part, mesorectal fascia, and this fascia is the retrorectal space, and this is presacral fascia. Behind that see the vessels, median sacral vessels. Okay, so for downward mobilization, divide the rectal stalk or lateral ligaments, lateral rectal ligaments which contains the middle rectal vessels. Then during excision of the rectum, divide the recto-urethralis. See some longitudinal muscle fibers from the lower part of the rectum that passes laterally and connected to the sphincter urethrae muscle. So that part is called the recto-urethralis. So divide the recto-urethralis before excising the rectum. Then access during the mobilization of the rectum, reach the retrorectal space by dividing the fascia of Voltaire. suppose if the surgeon fails to divide the Voltaire fascia and dissect more posterior to retrorectal space, so that leads to severe hemorrhage due to injury of the sacral veins. Okay, next. So now come to the arterial supply of the colon. See, all these structures which are derived from the midgut are supplied by branches from the superior mesenteric artery, because superior mesenteric artery is the artery of midgut. So the cecum is supplied by the ileocolic branch artery, then ascending colon by the right colic artery, then the transverse colon is mostly supplied by the middle colic artery, and near the left colic flexure it is supplied by the left colic artery, that's a branch from the inferior mesenteric artery, because the distal 1/3 of the transverse colon is developed from hindgut. So this region is supplied by a branch from the inferior mesenteric artery, that is left colic artery. Then the descending colon sigmoid artery, these are supplied by the left colic branch, then sigmoidal branches. Okay, then the rectum is supplied by superior rectal artery, that is the continuation of the inferior mesenteric artery. Then here all the arteries near the colon divide into ascending and descending branches and forming a continuous arterial arcade. This is called marginal artery of Tremont. Okay, then from the arterial arcade straight vessels arising, which are called vasa recta. Then near the mesenteric border each vasa recta divides into vasa brevia and vasa longa. Then the vessels piercing the colonic wall and supplying the entire thickness of the wall. Okay, then this is drained by the corresponding veins. Okay, so the veins from the cecum, ascending colon, proximal 2/3 of the descending colon, all the veins, they are accompanying their corresponding arteries and drain into the superior mesenteric vein. Then veins from the distal part, distal 1/3 of the transverse colon, descending colon, sigmoid colon drain into inferior mesenteric vein. Okay, what is diverticulosis? See, these are clinical condition in which multiple small bulges are present over the outer surface of the large intestine. This is due to the outward bulging of the mucosa, okay, through the weak sides of the colonic wall. Mostly the weak sides are formed by the penetrating of the blood vessels. Okay, infection of this diverticulosis causing the diverticulitis. Then here, see the middle colic vessels, see the trunk is mainly present in between the two layers of the transverse colon, mostly on the right side. So in case of surgical opening of the transverse mesocolon, try on the left side. Okay, then right colic vessels, left colic vessels, they are retroperitoneal. They cross their corresponding gonadal vessels and corresponding ureter. Okay, then you know the critical point of SUDAC, that is failure of anastomosis between the superior rectal artery, that is recurrent branch from the superior rectal artery, and also the lower sigmoid artery. Then sometimes a direct retroperitoneal anastomosis occur between the trunks of superior mesenteric artery and inferior mesenteric artery, that is called arc of Riolan. Now come to the blood supply of rectum, that is supplied by superior rectal artery, so that run along the posterior surface. Then it divides into two lateral branches. Then each branch divides into many small branches, and that pierce the wall, and that making plexus in the submucosa. Okay, from the submucosal plexus, the straight arteries are running along the anal columns and supplying the anal canal also. Okay, then this is also supplied by the middle rectal artery from the internal iliac artery, then inferior rectal artery from the internal pudendal artery. Then venous drainage. So here there is an internal venous plexus is present in the submucosa. Okay, from the upper end, radicals extending upward and unite to form the superior rectal vein that drains into inferior mesenteric vein. Then from the sides, the middle rectal vein arises that drains into internal iliac vein, inferior rectal vein into internal pudendal vein, then again into inferior internal iliac vein. So here, by this rectal veins, there is an anastomosis occurs between the portal and systemic veins. Next. So here, the superior rectal artery that pierces the posterior rectal wall 7.5 centimeter above the anus, and the radicals of the superior rectal vein has no valves. So in chronic constipation, there is a distension of radicals of the veins, and in portal hypertension also the distension occur that leads to the internal hemorrhoids. Okay, in the common sites, the primary sites are left lateral, right posterior and right anterior. And the lymphatic drainage, so the lymph vessels also accompanying their corresponding arteries. So these are divided into 4 groups: epicolic nodes, paracolic nodes, intermediate colic nodes, pre-terminal nodes. Epicolic nodes are present over these are minute whitish nodules present over the surface. Paracolic nodes are present along the medial border, mesenteric border. Okay, then intermediate colic nodes run along the courses of the arteries. Then pre-terminal nodes are present around the trunks of the major artery, superior mesenteric artery and inferior mesenteric artery. Then in radical lymphadenectomy, remove all the highest possible lymph nodes of the particular region of the rectum. In carcinoma of the rectum, remove all the pre-terminal lymph nodes which are present along the course of the arteries, along with divide the inferior mesenteric artery near its aortic origin. Next. Finally, nerve supply. So it is supplied by both the sympathetic and parasympathetic fibers. The right colon is here, the sympathetic fibers are coming from the T7 to T12 spinal cord segments. Then postganglionic fibers are coming from the celiac and superior mesenteric plexus. Okay, then the left colon, here the preganglionic fibers are coming from L1, L2 spinal segments, and the postganglionic fibers are coming from the inferior mesenteric plexus, superior hypogastric plexus. Okay, then the parasympathetic for the right colon is from both vagus, and the left colon is through pelvic splanchnic nerves that carries S2, S3, S4 fibers. Okay, so this is about the anatomy and its applied aspect of colon. Thank you.
Thank you very much, ma'am, for enlightening us through the nuances of the applied anatomy of colorectum. For the second session, we would like to invite Dr. Sundaram sir, Head of the Department of Surgical Oncology.
Professor Dr. Sundaram sir has done his MBBS and MS General Surgery at Madurai Medical College. He has pursued his MCH in Surgical Oncology from Kilpak Medical College. Sir has also served in various hospitals like RCC Kanjipuram and Madurai Medical College. He is a person who has always shown his keen interest in the academic growth of the students and is also a great teacher. I now invite Dr. Sundaram sir, Head of the Department of Surgical Oncology, TVMCS, to enlighten us on the topic and approach to colorectal malignancy and its evaluation.
Thank you, Doctor, for the introduction. A very good morning to all of you. Actually, colorectal cancers are so very common, and it is part of the screening program abroad. But in India, we don't have a screening program for colorectal cancers. So we'll just go through the incidence, clinical features, and the various investigations that are to be done, and a slide about the newer things in the colorectal cancers. Right. So this is what we are going to go through next. So as I said, it's a very common problem in US, almost 10 times the incidence of the colorectal cancers in India. But still, in India also, it is the 4th common cancer among men at least. Next. So age itself is a major risk factor for colorectal cancers. So the screening program, it starts from 50 years for the average risk individuals, and for people with the higher risk, it starts a decade earlier. So the incidence is relatively higher as you age. So you can see in that slide, lifetime incidence is about 5% the risk, whereas it is 90% if it is above the age of 50. And certain inherited conditions predispose to these cancers. Next. And of late, what we have seen is a gradual shift in the incidence of cancer from the left colon to the right colon. This has been observed both in the US as well as internationally. And the greatest increase in the right colon occurs in the cecal region. Next. So why these changes have happened? One thing is, it may be related to the better diagnostic improvements. That is, commonly now they use sigmoidoscopy to screen as well as double contrast barium enema to screen cancers. So that might pick up early pre-malignant lesions on the left side, and that might be treated endoscopically itself. So the invasive cancer incidence appears relatively less on the left side, whereas on the right side it remains same. There's also a true increase in the incidence of the cancers in the ascending colon and cecal cancers. Next. So if this hypothesis holds good in the sense that the 5-year survival rate has improved significantly for the left side and the transverse colon, whereas for the right side it is not so. Because we have identified it earlier, because it can be easily, even with sigmoidoscopy, you can pick up the left sided cancers. So what are all the risk factors for colorectal cancer? So the risk factors, as in any other cancer, can be divided into environmental factors as well as genetic factors. If you are aware about the basic genesis of pathogenesis of cancer, you will know what is called as Knutson's two-hit hypothesis. That is basically an inherited, that guy is prone for the cancer, and the second hit, that is the first hit. And the second hit is the environmental factors which predispose to cancer. So when both hits are there, the chances of getting cancer is high. That is what is called as Knutson's two-hit hypothesis. So, but having said that, there is some inherited cancers. The majority of them are sporadic cancers. Next. So a personal or a family history of sporadic cancers or polyps itself is a risk factor for colorectal cancers and adenomatous polyps. Next. So what are all the hereditary diseases which can cause colorectal cancers? Familial adenomatosis polyposis, then hereditary non-polyposis, what is called as HNPCC, colorectal cancer, and a personal history of large, more than 1 centimeter adenomatous polyps and polyps with the villus or tubulovillus histology. These, if during any colonoscopic examination, if such polyps are there, the very fact that they are there has an increased risk for colorectal cancer. So this risk averages around 3.5 to 6.5, the relative risk. Next. Family history is also important for sporadic disease. So if you see the various screening recommendations abroad, that includes the various types of family history that will be included in that. Any standard textbook will give you the Bethesda as well as other systems of screening protocols. So a single affected first degree relative has an increased risk of about 1.7-fold that of the general population. You know, the first degree relative means parents, sibling or children. So a family history of more than 1 centimeter adenoma also appears to carry the same significance. Next. Apart from these polyps, what are all other predisposing factors for colorectal cancers? So inflammatory bowel disease like ulcerative colitis and regional ileitis, diabetes mellitus and insulin resistance obesity. These are also observed to have more incidence of colorectal cancer. And cholecystectomy, history of cholecystectomy as well as alcohol use is known to have increased incidence of colorectal cancer. One other interesting observation is history of radiation therapy for prostatic cancer increases the risk of rectal cancer. Next. These are all the predisposing factors, but there are certain protective factors also, which are also observational studies. So certain diets which are rich in vegetables can protect against colorectal cancer. Diets which are rich in fibers, they can also protect colorectal cancers. And calcium supplementation, it has been shown to protect colorectal cancers. Next. So there have been trials with aspirin and other NSAIDs for their protective effect against colorectal cancers. Omega-3 fatty acids, which is commonly given as a food supplement, has also protective against the colorectal cancer. So this is about the protective factors and the predisposing factors. Because it's such a big magnitude societal problem, screening is advised abroad. So patient surveillance as well as the general population can be we can do surveillance by doing a colonoscopy. For the average risk individuals, the American Colonoscopic Society, it gives a recommendation of doing every 10 years colonoscopy starting from the year 50th age. If an adenomatous polyp is identified in such screening process, then the colonoscopy should be repeated every 3 years until it is clear for every 5 years. Suppose the patient has got a high risk factor like early family history, etc. Then the colonoscopy screening starts earlier at 40 years and is done every 5 years. Next. So that is about screening. Then we can go to the clinical presentation of colorectal cancers. So these are all the various percentages of the presentation. Commonly you get abdominal pain or a change in bowel habit, hematochezia or melena. Some patients may have weakness because of the generalized cancer cachexia, and patient may have anemia, may be the primary presentation. This you should be very careful in an elderly patient. Suppose a patient is presenting with just anemia, no other GIT symptoms, and anemia and weakness, you have to evaluate always, especially in elderly male patients. You have to look for either a subtle bleeding which may not be noticed by the patient, or in case of multiple myeloma also, it presents with anemia. So you have to have this in the back of your mind, especially in male patients. And some may present with weight loss. So if you see, it is not a very sensitive feature. The alarm features like weight loss is not a very sensitive feature. However, the specificity of some alarm symptoms like dark red rectal bleeding and abdominal mass was great, and it was around 95%. It is specific for colorectal cancer. So regarding pain, what are the causes of pain of colorectal cancer? It may be due to partial obstruction, or an extensive disease may cause peritoneal dissemination, and intestinal perforation may also lead to generalized peritonitis. Some rectal cancers may cause tenesmus, and in case of certain locally advanced rectal cancers, they might involve the sciatic nerve or the obturator nerve. So this may lead to neuropathic pain. Hematochezia occurs in left-sided cancers, especially rectal cancer, whereas a change in bowel habits is more common in case of left-sided cancers, because the fecal content on the right side is liquid. So the change in bowel habits is noticed more on the left-sided cancers. Actually, in Walian love, there will be a tabular column showing the features of left and right-sided colorectal cancer. It's worth going through that. Actually, it is a common observation that you can have. So sometimes presentation itself will be a metastatic disease. Our founder of MCH course in Chennai, Snehalada madam, she was diagnosed with colorectal cancer in the metastatic stage. She had a liver metastasis, only then we were able to know that she had cancer. So sometimes the presentation may itself be a metastatic disease. So prognosis is poor when the extensive metastasis is present. So how will you know that? The presence of right upper quadrant pain, abdominal distension, early satiety, supraclavicular adenopathy, these are all signals of advanced disease. So where will the metastasis commonly go? because it is drained by portal system and colorectal cancer spread by hematogenous route. Commonly, the liver is the site of metastasis. So our metastatic workup will be directed towards liver. What is the other organ which can be involved by hematogenous spread? It is the lung. It is more common in rectal cases, and because madam said in the anatomy, so there's the portosystemic anastomosis, and the inferior rectal vein drains into the inferior vena cava, so that goes to the lungs. So in rectal cancers, especially the distal rectum, the metastasis may be into the lungs first. Next. There are also some unusual presentations like internal fistulation with the adjacent organs, especially in rectal pelvic, in the tight compartment of the pelvis. It might perforate into bladder, so urinary bladder, and these patients may be may present with symptoms of what is called as pneumaturia. They might be passing air through while urinating. So it is common mode of presentation sometimes. Sometimes it may be a fever of unknown origin. Patient will just be having a low-grade fever, no other symptoms. You have to work up these patients towards colorectal cancer. And sometimes there may be metastatic node elsewhere with an unknown primary. If you work up, if you do immunohistochemistry, all those things from the node, you will know that it might be arising from a colon. So it is 6% of such cases are arising from colon. Next. So the symptoms itself, they have some impact on the prognosis. So patients who are symptomatic at diagnosis have somewhat worse prognosis. This is logical because if by screen detection or incidentally found out cancers may not be that invasive. So they will be in an earlier stage, so their prognosis is relatively better, whereas those patients who are presenting with symptoms, they have a worse prognosis. Next. And similarly, obstruction and or perforation has got a poor prognosis. Whereas patients presenting with hemorrhage, they have a better prognosis. For the simple reason, hemorrhage is an alarming symptom and it will be worked up immediately, and most of the cancers will be early cancers, usually visualizable with the sigmoidoscopy or even proctoscopy. Colorectal cancer is one cancer where a synchronous presentation is known. It's not very uncommon. So what is the definition of synchronous malignancy? It is defined as two or more distinct primary tumors which are separated by normal bowel mucosa and is not due to direct extension or metastasis. And it occurs in about 3 to 5% of patients with colon cancers. So what is metachronous cancers? Metachronous cancers are defined as non-anastomotic new tumors developing at least 6 months after the initial diagnosis. So you do a resection and do an anastomosis. If within 6 months there is a growth in the anastomotic site, it won't be considered as a metachronous tumor. Whereas if it occurs in either of that colon away from the anastomotic site, after 6 months it will be taken as metachronous cancer. So again it develops in about 1.5 to 3% of the patients. That is why in the initial first 5 years. So that is why the follow-up of most of the cancer patients is very intensive for the initial 5 years. Next. So how do you diagnose colorectal cancer? So by the various symptoms you may have a idea, and there are certain investigations which we will see subsequently for the diagnosis of colorectal cancer. So the best investigation of choice for colorectal cancers is colonoscopy. Previously barium enema was used, and even now barium, double contrast barium enema is a good way of even screening for colorectal cancers. But of late, colonoscopy is the single best modality for diagnosing colorectal cancer. So why it is advantageous? Because it can localize lesion throughout the large bowel, and you can biopsy the mass lesions, and you can detect synchronous neoplasms or pre-malignant conditions also you can diagnose. You can remove suspicious polyps. So intervention is also possible with the colonoscopy. The same sensitivity can be achieved with the air contrast double contrast barium enema in association with the flexible sigmoidoscopy. When both are combined, they have almost the same equal results with the colonoscopy. Next. But what are the disadvantages of colonoscopy? It needs a very good preparation. It is invasive. Some people may require sedation, and the risk of perforation is there, even though it is very minuscule, less than 1%. So that is about colonoscopy. Then we'll go on to imaging. Ultrasonogram is always advisable before we go on to CECT. For the simple reason, it can detect a very advanced disease presenting with the liver metastasis, multiple liver metastasis, and ascites, as well as other mass lesions. And sometimes even you can even diagnose obstruction with the ultrasonogram. But the problem is ultrasonogram is subjective. The surgeon may not be able to read the ultrasonogram effectively. It is an initial, as I said, in case you suspect a locally advanced disease or metastatic disease, ultrasound is better than CECT because it can do away with the CECT if the patient is going to have a multiple metastasis and a very advanced disease. CECT will be of no use in such cases. So next is contrast enhanced CT scan of the abdomen. For the imaging purpose, this is the best modality for colon. We can divide colon and rectum and go accordingly. Even for rectum, it is very good, but MRI scores over CT scan in certain aspects. So what are all the advantages of CECT? In colon, it can identify mass lesions. It can identify luminal disease. It can identify peritoneal disease. It can identify liver metastasis. It can identify nodal disease. And of course, ascites can be picked up. வந்துருச்சுப்பா வந்துருச்சு. ஆயிடுச்சுப்பா.
Sorry for the interruption. It was due to a power failure. We have resumed now.
Next slide. So MRI, it is useful when CECT is contraindicated. Like for example, a patient who has got a contrast allergy or a patient with elevated renal functions where contrast cannot be used. In such cases, you can use MRI. As I said, in rectum, it has an advantage over CT scan because of the better delineation of the soft tissues and better you can have a sagittal view in addition to axial and coronal cuts. So when you add endorectal coils for which is dedicated for rectal imaging, you can identify even early T stage with the MRI. Next. There is one other useful modality which is commonly used in high volume centers is endoscopic ultrasound. So this again It's a very useful in early cases where you can delineate the T stages and the N stage. So this is useful in cases where you can do rectal sparing procedures through endoscopy like TEM. So next. So PET-CT scan. PET-CT scan is not routinely advised in as a part of metastatic workup, but it can be used for identifying recurrence, especially when you are going to treat it with a curative intent. You would like to know whether there is any spread in the rest of the body, and we can also use it to assess response evaluation. So based on the SUV value, what is called a standard uptake value, and it's coming down with systemic therapy, you can know that this tumor is responding to chemotherapy. So it is also used for following up patients with the systemic therapy. Next. So the TNM staging is standard it's given in any standard textbooks. I just rush through this. Next. Next. A word about the N categories. See, minimum you have to harvest 12 nodes. That will be done by your ligation of the named vessels at its origin. Then when the nodes are harvested and if the involved nodes are checked, it is divided into N0, N1 and N2. N0 is no nodal involvement. N1 is when 1 to 3 lymph nodes are involved, and N2 is 4 or more lymph nodes are involved. This is important because it is used in stage grouping, which gives out the prognosis. Next. So M category, as you know, no metastasis, or my M1 is with metastasis. Next. So this is a stage grouping. I have summarized it in a slide separately. Next. 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 So it's a simple way of remembering the stage grouping. That is, 0 is in situ cancer, and stage 1 is no nodal involvement, but T1 and T2 primary. Stage 2 is again no nodal involvement, but T3 and T4 primary. So stage 3 is N plus disease. So it will be again subdivided into A, B, C according to the N1 or N2 node involvement, and stage 4 is metastatic disease. Next. So as I said earlier, rectum presents earlier in an earlier stage because of its alarming symptoms. Next. But metastatic colorectal cancer is not bad after all, provided the metastasis is treatable and within the stipulated number of meds. So the 5-year relapse-free survival for metastatic cancer, which is treated with the curative intent, is somewhere around 25 to 35%. So it is very good for a metastatic disease. So apart from the imaging, you have to do on opening the abdomen, you have to go through the what is called as exploratory laparotomy. You have to do, I think Balamurugan will be speaking about that. You have to look for synchronous disease as well as other meds in the likely areas of metastasis before embarking on a curative surgery. Next. So as you have seen that in the previous one, the last point says that peritoneal disease is, if it is of low load, it cannot be identified by CT scan. So a word about tumor markers. So the common tumor marker that is used is carcinoembryonic antigen, but as a standalone test, it cannot be used as a screening test. But if it is elevated, it gives a idea about a prognostic significance. That which has a preoperative value of more than 5 nanogram has a poor prognosis. Next. So tumor markers again can be used for assessing the response to systemic therapy. So if the patient is given adjuvant therapy, if the tumor markers stay low or disappear, then you know that this disease is responding to your treatment. And again, for follow-up, you keep these patients under follow-up, the tumor markers may show up earlier than a imaging modality to pick up cancer. So that is the advantage of tumor markers, but the condition is the tumor marker should have been raised initially if it is to be used for these purposes. Next. This is the last slide. It is about what is something new which has happened in colorectal cancers. For the diagnosis and screening, they have come out with some stool-based test which tests the DNA array. They've got some kit by which they can identify certain array of DNA which detects CA colon. Similarly, they have come out with the blood test. Here, what is called as epiprocolon, that is one gene which they identify to detect colonic cancers. And again, in all newly diagnosed cancers, we should test for microsatellite instability. It gives out prognosis. Those with microsatellite instability on the right side at colon has got a better prognosis, whereas on the left side it is a lower prognosis. So similarly, all metastatic CA colon should have test for what is called as KRAS, NRAS and BRAF mutation. And these are all mutations which can be identified. These facilities are available even in India. Medical oncologists and standard oncological centers practice this. They identify these mutations because if it is a mutant variety, then these patients will not benefit from what is called as the cetuximab and panitumumab. So these are all targeted therapy. This will not be useful in patients who have mutations in this KRAS, NRAS and BRAF mutations. Thank you for your patient listening.
Thank you, sir. That was such an excellent session. As a token of our gratitude, we now request Dr. Rajashekar sir, Chairman, ASI Tamil Nadu Chapter, to honor Dr. Sundaram sir. Thank you, sir. I now request Dr. Balamurugan sir, Honorary Secretary, Tamil Nadu ASI, to honor Dr. Jayanti ma'am, our first speaker. Thank you, sirs, and thank you, ma'am. For the next session, we would like to invite Dr. BKC Mohan Prasad, sir. Dr. BKC Mohan Prasad, sir, is an energetic and an awesome educator. Sir has pursued his undergraduation and post-graduation from Madurai Medical College and had completed his MCH in Surgical Oncology from Adayar Cancer Center. Sir is always a gold medalist right from MBBS to his MS General Surgery and in his MCH Surgical Oncology. Throughout his career, he had devoted a major part in teaching out students and has served as the professor at Madurai Medical College. He has been the president of Indian Association of Surgical Oncology for 2 times and is now the governing council member of the same. We are happy to have you, sir. With great pleasure, we now invite Dr. BKC Mohan Prasad, sir, to enlighten us on the topic, management of colonic malignancy.
Thank you very much for your nice introduction. First, let me answer Professor Sundaram's question. Have you been vaccinated? Second dose. Yes, Sundaram, I have been vaccinated. And Tirunelveli, I come many times. It always gives me immense pleasure because it gives me an opportunity to meet our National President IMA, Professor Jayalal, who is also a surgeon, our TNASA Chairman, Dr. Rajshekhar, our Secretary, Dr. Balamurugan, my senior friends like Professor Pandi, Professor Ismail, Professor Sam, and my dear brother and HOD, Professor Alex, and other members of the Department of General Surgery. It is very nice that you have been the new seminar hall. I was fortunate enough to give the lecture on the first day of new seminar at Madurai Medical College also, and similar arrangements. And next, I bring wishes and greetings for the postgraduates. Next link. From the temple of Madurai Meenakshi to the temple of Nallayapar. Slide. Next. Without the Mata, Pita, Gurus, Deivam, we cannot flourish much in our life. With respects to my teachers, Professor Santa, who recently passed away, and Professor Krishnamurthy, who is my mentor. Next. And I also thank our Honorable Chief Minister, who realized the services of the senior surgeons and participated in our ASI meeting and gave awards to the senior members of the ASI. And I thank our chairman, Professor Rajshekhar, for the immense efforts he has taken to bring the CM to our association, that is the Cancer Day Awareness Function for Polish people. Slide. Slide. Colonic cancers, as already pointed by Sundaram, it is around 6 to 7 per 100,000 population, and most of the colonic cancers, they are reachable within the sigmoid scope. That is why the rectal cancers have got a better prognosis, because they are diagnosed earlier than colonic cancers. Slide. The presenting features have been eliminated very much by the Sundaram, the pain abdomen, lump abdomen. Once the symptoms start, the prognosis become bad. That is always, the more advanced disease, you have more symptoms. But what I would like to emphasize is one symptom which is usually forgotten and missed by many of the practitioners, the unexplained anemia, especially in a male patient. Very, very important, because right colonic cancers are very much notorious, like renal cancers, to give only anemia, nothing else will be the features. And I have got experience of few surgeons who have been diagnosed little late because they have only anemia, nothing else, but on investigation they proved to have only right-sided colonic cancers. So the unexplained anemia is also, that is not a common presentation, but that is one of the presentation which can misguide us, because and especially in a male, and this has to be taken care. Slide. Very well pointed out by Professor Sundaram. Various ultra-modern modalities have not increased the survival significantly. It is very important. We have got many methods. We have got laparoscopy, we have got robo, we have got open method, we have got so many tries have been tried, no touch technique and all these things, but not much of improvement in the survival. And the most important, the survival purely depends upon the stage of the disease at the time of initiation of treatment. That is the most important point you must remember. The advanced disease, bad prognosis. The earlier intervention, earlier treatment, good prognosis. That is what is more important in colonic cancers. Slide. Prerequisites. Any colonic cancer, as you know, it is all liquid feces or a solid fecal material. A good mechanical and oral bowel preparation. Either a mechanical bowel preparation may be in the form of edema, in the clinics or the nursing homes or hospitals. The oral preparations are very much available, like peg, like everything, it cleanses the bowel. But very important, oral preparations cannot be given in obstructive lesions. That is the most important thing you must remember. See, if you give in obstructive lesion, definitely you lead to perforation or something like that. So that is a oral bowel cleansing is contraindicated in obstructive lesions, whereas in non-obstructive lesion is a very good method of preparations. And usually we prefer to give perioperative systemic antibiotics and no touch technique and clamping the pedicle first. All these things are tried, and but the long-term trials have not proved them superior to the other methods. Slide. The pre-treatment evaluation very important. As Professor Sundar has told, the synchronous cancers are more common in colorectal malignancies. So you have to find out the extent of the disease, for which the colonoscope is the best answer. The double contrast barium is useful still, and governments like ours. And it is called as the air, and this is the barium, the Malmos technique. The condition of the rest of the bowel and comorbid conditions. A prognosis in a non-diabetic patient is definitely better than a prognosis in diabetic patients. So the comorbidities must also be well taken care. Slide. Preoperative preparation, I already told, bowel preparation, antibiotics. Another thing, the DVT prophylaxis. The very important, most of the colonic cancers, sometimes the patients are very obese. So a DVT prophylaxis is very useful, because you may do a very good surgery, you may do a very good anastomosis, but you may lose a patient in a pulmonary embolism following a thrombus in the deep veins, like that. So a DVT prophylaxis in selective patients where you expect the post-operative problems, it is very much better. And all colonic cancers and rectal cancer, preoperative stoma advice and planning must be done. This is very important, because the stoma planning comes under one of the important prerequisite category even under the NCCN guidelines. So the stoma advice, how they are going to, where are you going to place the stoma, how to take stoma care, all these things must be taught to the patient preoperatively, and not out, because when a patient sees a stoma without any information prior to surgery, it may itself give a very big mental shock to the patient. So a stoma advice must be done preoperatively. Then, what is the principles in colonic cancer surgery? Radical surgery when cure is possible, palliative surgery for procedures when cure cannot be obtained. Slide. Radical resection, it is always the adequate margin of normal colon and associated, very important, vascular pedicle as much as the corresponding limb-bearing structures. You have to exercise along with the limb-bearing structures as much as possible. Slide. The extent of resection, it is determined by I was listening to the anatomy by the Jayanti, it was very nice. The entire colonic resection are based on the blood vessels and the blood supply, that is very important. And 5 centimeter margin, both the distal and proximal, is adequate margin colonic resections. And resection of the intermediate and the principal nodes is a must. It is oncologically, it is to be done in all colonic cancer surgeries. Slide. The margins of resection is 5 centimeters, already I told you. It is sufficient. If you give more margins, well and good, but it should not be less than 5 centimeters. Slide. So already the vascular pedicle has been shown. All these resections are based on the vascular supply of the colon. Slide. This is how it is based on the either right hemicolectomy or a transverse colectomy or left hemicolectomy or sigmoidectomy, like that. Slide. So this already, depending on where is pedicle, ileocolic, right colic means a right hemicolectomy, like that it goes, and it is all given in books. Slide. Extent of lymph node resection. This is very important. Why should we do a lymph node resection in all oncological practices? Sometimes it is very useful, sometimes it is useful. Whereas in the extent of lymph node resection, colonic cancer surgery is very useful for staging, for preventing local recurrence, and a curative intent. It gives a cure. We don't develop any nodal recurrence in the future. Slide. Lymphadenectomy, already I told, it should extend up to level of the primary feeding vessel, and suspected partial lymph nodes outside the stand. Suppose you got a primary feeding vessel, there are got outside lymph nodes also, you can excise that, but the minimum 12 lymph nodes must be harvested. The number in colonic malignancies, harvesting lymph nodes must be 12 minimum. Slide. So this is how it looks after the resection. Slide. Techniques of good anastomosis. What is a good anastomosis? Most important prerequisite, well prepared bowel, minimum spillage, very minimal soft tissue handling, perfect hemostasis, accurate apposition. This is very important. See, whether you put a 2-layer or a single layer, interrupted silk or contest, they are all secondary. approximate, appropriate approximation is very, very important. Whether you put a single interrupter 20 silk or 20 Weichel or double or whatever it is, correct apposition is the most important factor. And anastomotic leakage, it occurs, sometimes it may lead to even lethal complications. Slide. Continuous organ involvement, very important. Colonic cancers, when the organs are, adjacent organs are involved, resect it in total, don't separate it. This is another important point. Suppose the colonic cancer is there, it has infiltrated the mesocolon, it will infiltrate the omentum, it has infiltrated the adjacent structures like that. You resect it en bloc. Don't dissect out the adhesions and then resect it. That is a message. Slide. Already I told adhesions should not be divided, it should be resected en masse. Slide. Principles of resection, already I have told you. En bloc resection should be performed. Don't perforate the bowel, because bowel perforation totally alters the prognosis. A thorough abdominal exploration, already Professor Sundaram told, a thorough exploration for a synchronous cancer, proximal cancer, distal cancer, very, very important colonic cancers. The no-touch technique is not very much useful. Bowel washout will also not to be proved of much benefit. If the ovaries are involved, a ovaries can be removed. Even some people practice prophylactic oophorectomy in colonic cancers. Slide. Minimal access, whether it is laparoscopic or robotic, is easily proved as good as open surgeries. Now people claim that even it is better than open surgeries in the form of pain, other things. But one caution word, though there is a no randomized trial, when there is serosal involvement and pericolic spread, the minimal access surgery leads to more metastatic complications than open surgery, because there is when you use air and other things, if you do it under non-air technique, that is different. If you do it under blow out the abdomen, there is a chance for the periserosal tumor cells to spread all over the abdomen. And even we have lost some of the very famous surgeons because they underwent a minimal access colectomy with periserosal spread and extraserosal spread. Slide. Upstanding cancers, what will you do? They are upstanding cancers. Either you do a colostomy and do a delayed resection, or you do a resection and bring out both the loops outside and then do a delayed anastomosis, or you resect and immediate anastomosis and do a diversion ileostomy or something like that, or you do an entire subtotal colectomy. Slide. Primary resection anastomosis, when will you do? Outstanding, upstanding cast on the right colon, provided there is no complication. In fact, the patient is not a diabetic, the bowel is not very much loaded, and all these things. And the most important, the operating surgeon must have the necessary expertise. That is very important. Following on-table lavage for upstanding carcinomas, you can empty then and then do anastomosis. But the most important, the surgeon must have the good expertise in anastomosing the bowel. Slide. Colostomy, when will you do? When the patient has got multiple risk factors, diabetic, fully loaded colon, immunosuppressed individual, etc., obstruction with perforation, and there is a generalized peritonitis and viable but diffusely injured bowel. Slide. Already I told, when we do perform a subtotal colectomy in colonic cancers, when there are synchronous cancers or polyps and a colonic cancer associated with ulcerative colitis. Slide. Palliative procedures, you are not able to resect, there are multiple liver secondaries and there are multiple parietic nodes, etc. Your treatment is not going to curative, then what will you do? Resect and anastomose whenever possible. Creation of stomas is better for the patient avoided. And you got alternative non-surgical procedures like laser coagulation and stenting, etc. But even for palliation, the margins must be negative. Margin positive resection should not be done. Next. Non-operative palliation, already told, you got a laser, the endoscopic stenting, etc. Slide. Non-operative palliation, this is laser coagulation of the colonic polyps. Slide. Slide. Stenting. And the stenting is sometimes useful to obliterate the fistulae also. Slide. Then already Professor Sundaram told colonic cancers are diseases where you can give a good prognosis even in the presence of liver metastasis or lung liver metastasis when they are resectable. Very important. The entire liver is involved with liver mets, you cannot do much. When they are resectable, definitely it should be resected. Slide. It can be in the form of either a non-anatomical resection or it may be segmentectomy or a right or left lobectomy, etc. Slide. 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 What are the contraindications? You cannot go and resect every liver metastasis. When there is a diffuse liver involvement, disseminated extrahepatic disease, when they are the primary is not well controlled, and when they are not able to achieve margin-free resection for the primary and arterial liver function and poor performance status. These are the contraindications for liver resections for metastatic colorectal cancer. Slide. What are the predictive factors? How will you know this patient will do well or not? The performance score, already Professor Sundaram told, the cosmogenic antigen, the nodal status, the grade of the tumor, the size, number, location of the metastasis, and most important, the disease-free interval from the primary surgery and the development of metastasis. It should be minimum 6 months, then only the prognosis will be good. And technical factors, negative resected margins. If there is a positive resected margin, definitely it will recur. Slide. Adjuvant therapy. Now Sundaram also mentioned there are a lot of adjuvant therapies, rather targeted therapies are coming up in colorectal cancers. In colonic cancers, what is the role of adjuvant therapy? To eradicate micrometastatic disease, to improve survival after curative resection. Colonic cancers also get benefit by adjuvant therapy. Their survival gets increased. That is very important. Slide. When will you advise adjuvant therapy? Inadequate lymph node sampling. When your lymph node sampling is less than 12 nodes. T4 lesions, perforation, poorly differentiated histology like the poorly differentiated tumors, etc. And already Professor Sundaram was touching upon that. We have to do all these immunohistochemical studies. When the microsatellite instability is very high, it is got a good prognosis. Similarly, when there is loss of heterozygosity at the 18q chromosome, there is a bad prognosis. So apart from the histopathology, today you have to do a molecular study also for colonic cancer. That is the message. Slide. What are the adjuvant therapies you give? Adjuvant chemo. When I was a student in 1985 MCH, only 5FU. Then came 5FU plus vincristine, semester, etc. Then 5FU plus leucovorin. Then comes the Folfox, oxaliplatin plus 5FU and leucovorin. Then comes the Folfry, irinotecan and 5FU plus leucovorin. All these things, were depending on various strains, they have come. Today, very popular regimen is the capecitabine, which is a oral 5FU derivative with oxaliplatin. That is more popular now as an adjuvant therapy for colonic cancers. Slide. Is there any role for adjuvant art in colonic cancers? Yes, but it is not as good as required as CA rectum. Very minimal role. What are they? Slide. Positive margins in T4 disease. Suppose you are doing a cecal growth, you are not able to do R0 resection. There is a adhesions and the residual disease over the cecal bed in the retroperitoneal region, and then attend pelvic structures. Definitely there is a role for local radiotherapy along with chemotherapy. Slide. Apart from that, the radiotherapy is also done as intraoperative radiotherapy. See, it is not very common nowadays because we are able to evaluate the disease very well preoperatively, unlike olden days where you do a laparotomy and proceed. In spite of that, you open, the growth is fixed, you are inoperable, you can give intraoperative radiotherapy, you got the facilities for that. Slide. Another important role for radiotherapy is a hemostatic radiotherapy. So the patient is bleeding and the patient is not fit enough to undergo emergency surgery, then definitely hemostatic radiotherapy is useful, especially in CA stomach, CA colon, CA rectum, etc. Which is a short dose of radiotherapy they give, which is hemostatic, thereby control the bleeding. Slide. The genes associated, already very well discussed, the various genes, the P53, CAVE2, CA19/9, these are associated so that you can target the genes in your targeted therapy. Slide. The monoclonal antibodies already Sundara touched. You got the bevacizumab, nivolumab, pembrolizumab, etc. All are very expensive, but there are indicated cases if you got, definitely they got some benefit. Slide. Vaccines are also coming up, like corona vaccine. The CA vaccine is tried. They are all irradiated autologous tumor cells with the BCG incorporated, but still they are under a trial only, not for regular use even now. Slide. Surgeon, this I want to stress in anywhere, there's a colon cancer, rectal cancer, stomach cancer, etc. The best results are obtained with a high volume surgeon, and medium volume surgeon can also have a good result in a high hospital also good. The surgeon is a most important factor as far as the oncological surgery and outcome is concerned. His experience, his volume, and the center in which he is working is very, very important for the prognosis. Slide. Recurrent disease. How will you manage after local therapy? You have done this recur. Suppose you have done a surgery, you can go for radiation or chemo. Suture line recurrence, always go back and resect if there are no distant metastases. Radical surgery recurrence, you can give only palliative chemotherapy. Metastatic recurrence, once again, is the palliative chemo or targeted therapy. Slide. There are certain new things like radioimmunotherapy surgery, where you incorporate the 19M technetium into the monoclonal antibodies against the antigen or the tumor and then give. These are tried but not very much useful. Slide. Role of aspirin and COX-2 inhibitors, they are trying that still no much benefit. Slide. How will you follow after colonic cancer treatment? Physical examination every 3 months for 3 years, then every 6 months for next 2 years. CA levels start increasing before the development of radiological metastasis if the CA level is already increased before surgery. Then yearly X-ray, chest, liver profile, ultrasound, etc. 6 months colonoscopy for 5 years. Slide. Pre-malignant conditions. What you must know is mainly important about the polyps of the colon. Slide. The screening is useful. You have got many options. You can either do a total corectomy with the iliorectal anastomosis, or a total proctocorectomy with the ilioanal anastomosis, or you do a total proctocorectomy with a ileostomy. And you have to do screening, etc. 24 years. Next slide. I will leave. Ulcerative colitis is also increased with the increased incidence of colonic cancers, and the age of onset is around 48 years. Slide. What is you must know about the polyp as an exam student? The size of the polyp, the histology, the number, morphology, these are all more important. What are high risk polyp? Villus polyps, more than 1 centimeter, multiple polyps, and sessile polyp. Sessile polyp is more dangerous than the pedunculated polyp. Slide. These are the various risks of malignancy depending on size of the polyp. Slide. Then, how will you manage a polyp? Pedunculated polyp, colonoscopic snaring or excision. You don't need to do a surgery. Only colonoscopy treatment is enough. Sessile polyp, less than 2 centimeter, you can do a colonoscopy excision, but it should not remove in piecemeal excision. Slide. After colonoscopy resection, when will you do a surgery for polyps? Pedunculated polyp with the lymphovascular invasion. Your excised polyp shows lymphovascular invasion, you have to do a colonic resection. Sessile lesions removed less than 2 millimeter margin. Sessile lesions removed as piecemeal. More than 3 millimeter sessile polyp and sessile polyps lymphovascular invasion. If you got the same findings in your pathology, you have to go back and resect the colon. Slide. This is how the algorithm of colonic polyp management. Slide. See this slide, this is a standard NCCN guidelines which I have put mainly because if you see the workup, you see the CA level, CT, enterostomal therapies as indicated for preoperative marking, site teaching, etc. So even the stoma advice and marking is incorporated in the NCCN guidelines itself as a preoperative workup. That is why I put that slide. All other things in the incident given I have covered up. Slide. 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 So in colonic cancers, what you should not forget, incidence of colonic cancer is increasing. As already pointed out, the right colonic cancers are becoming more and more nowadays than left colonic cancers due to altered food habits. Unexplained anemia to be evaluated carefully. Survival in colonic cancers mainly depends upon the stage at the time of presentation and the initiation of the treatment. Press surgery is still the treatment of choice, even the presence of metastasis. It's one area where you can do surgery even in the presence of metastasis when the metastases are operable. 5 centimeter margin on either side in unstretched colon. If you do only 3 centimeters, stretch the colon, it will become 5 centimeters. So very important, it's an unstretched colon. You must give 5 centimeter crease on either side. Laparoscopic, robotic surgery is as good as that open surgery. Adjuvant modalities are useful like chemotherapy, and I told some indications for very rare indications for radiotherapy. And future proposals like targeted therapy, bevacizumab, pembrolizumab, they are all still promising, but still needs further evaluation because the side effects are more and it is quite expensive. Thank you very much for the patient listening. Thank you.
Thank you, sir, for enthralling us to such a session. Before we move on to the next session, I now request retired professor and HOD, Dr. Muthukrishnan, sir, to felicitate Dr. BKC Mohan Prasad, sir.
I am very happy to receive the memento from a teacher, Professor Muthukrishnan sir, who was my anatomy tutor. When I joined in 1971 MBBS batch, sir was working with the Department of Anatomy and I was a student, and because of the teachers like him, I am what I am today. Thank you very much.
Thank you, sir. For the next session, we would like to invite Dr. Balamurugan, sir, Honorable Secretary, ASI Tamil Nadu Chapter. Dr. Balamurugan, sir, has completed his MBBS and MS General Surgery at Madurai Medical College and has pursued his MCH in Surgical Oncology from Kilpak Medical College. He has also pursued MA in Yoga from Bharatiya University. He has presented numerous research papers at both national and international oncological conferences. He is a member of Indian Association of Surgical Oncology, Association of Minimal Access Surgery, Association of Colorectal Surgery, and Indian Association of Gastrointestinal Endosurgeons. At present, he is also a Honorary Secretary of TN State Chapter of ASI. We take great honor in inviting Balamurugan sir to educate us on the topic of management of rectal malignancy.
Good morning to all. Respected Alex sir, Professor Kachodi, Tirunelveli Medical College, Jailal sir, National President, INA, Rajasekhar sir, ASI Chairman, Mohan Prasad sir, GC member ASI, and other senior professors, Maheshwari madam, and Payundaraman sir, and other seniors. Good morning to all. Today I enter into the auditorium, everybody wearing the ribbon, that is blue color. Why we selected blue color for this occasion is, cancer ribbon for colorectal cancer is blue. That's why as a one, I make my presentation in blue color. Before going into presentation, postgraduate should know some fact. You are the surgeon. When treating the rectal cancer, what you should know first? You should know sound knowledge of the disease, that is biology, how it occurs, disease progression, natural history. Why selection of the modality of treatment? There are many modalities, surgery, chemotherapy, radiotherapy, targeted therapy. Which should be considered, what should be given first, and accurate and skillful surgical technique. You are now operating surgeon. What is your challenge in treating rectal cancer? Your challenge is, you have the capacity to achieve simultaneously to cure the cancer. At the same time, your result will be minimal impact on quality of life. If you do APR with end colostomy, the patient will live with colostomy forever. It gives mental stress to the patient. So as a surgeon, with available expertise, with your knowledge, you try to avoid colostomy if possible. Before taking into treatment, what you should know first is site of the lesion, whether it is upper or middle, lower. Regarding lateral spread, whether fixity is there, adjacent organ invasion is there, nodal involvement, mesorectal node or a mesenteric node, and either metastatic or non-metastatic, distal spread. In oncology, there are two words is more important. One is site, another one is subsite. Every organ is site. Rectum is one site, breast is one site, stomach is one site. Subsite is in the structure we can divide based on oncological result, oncology decision making. There are three subsites in rectum, upper and middle and lower. What is rectum defined by site is an imaginary line drawn between the pubic symphysis to the sacrum. What is large bowel below is rectum. Oncology concept in rectal cancer. Treatment option. If it is operable, your plan is surgery plus or minus chemoradiation. It is inoperable. Inoperable is multiple metastatic lesion. Your aim is palliative, that is radiotherapy and chemotherapy. Treatment classification. After your assessment, after your all investigation, you will categorize lesion into 6 types. That is T1, T2 lesion of the upper and middle. Another one is T1, T2 lesion of the lower 1/3. Another classification T3 and above, and N1, N2 lesion of the any site. And T4, that is adjacent organ invasion. Another is metastatic lesion. We can categorize it into less than 3 in number in liver, single lung metastasis. These are still curable. We will do curative surgery. Last one is advanced metastasis, that is more than 3 liver metastasis, multiple lung metastasis. Based on 6 category, we can plan treatment. Treatment concept is T1, T2 lesion in the upper and middle, only surgery is enough. No adjuvant treatment is recommended. Just like same T1, T2, if it is in the lower 1/3, surgery plus chemoradiation is mandatory. T3 or N1, N2, any site, upper, middle or lower, surgery and chemoradiation is mandatory. If adjacent organ is involved, suppose rectal cancer, anteriorly placed structure, uterus, bladder involved, still it is operable lesion, you can do excision, ultra-radical surgery plus chemoradiation. Metastasis less than 3 in liver, single lung metastasis, it is still curable, you do excision of the metastasis, metastaticectomy followed by local treatment. Disseminated cancer, your treatment is palliative treatment. In reverse order, when only surgery is indicated in T1, T2 lesion of the upper and middle. In all other site, T3, T4 are node positive, all other lower site, chemoradiation is mandatory. Surgery and chemoradiation indications are T3, T4, node positive, lower rectal cancer, after conservative surgery, that is transanal surgery, TEM, transendoscopic mucosal resection, and before excision. It is the most valuable slide. If you plan surgery and chemotherapy, that is T3, T4 lesion or N1 lesion, which modality to be given? Chemoradiation, whether it to be given before surgery, after surgery. As a surgeon, we have stimulus, we have urge to do surgery, then we will give chemoradiation. It is the concept, mindset to every surgeon. Chemoradiation, when to given, either pre-operative or post-operative. Ideal is pre-operative chemoradiation. Allow chemoradiation, then you will do surgery, the result will be better. Why chemoradiation first followed by surgery? What are the advantages? If you give preoperative chemoradiation, it will cause regression of the tumor. Sometime first examination, spindle saving not possible, that is anterior resection not possible, you end up with APR. In that circumstances, if you do chemoradiation, it will cause tumor shrinkage, centripetal contraction of the tumor, elongation of the normal mucosa that converted into anterior resection. It gives better radial margin, your radial margin clearance is more, so chances of local recurrence will be high. And the size of the tumor will become decreased, so it is easy to do narrow pelvis, especially android pelvis, male pelvis. When the radiotherapy act better, when oxygen tissue concentration is higher, the radiotherapy will act better. After surgery, you divide many vessels, post-operative but always giving lower oxygen concentration comparing to pre-operatively. That's why radiotherapy effectiveness also better. Another one is, if you do surgery, post-operative radiation will cause colitis and mucositis that lead to radiotherapy complication. If you give radiotherapy before surgery, whatever irradiated colon, that will be resected in definite surgery. So post radiotherapy complication also less. That's why golden word in rectal cancer is, if chemoradiation is indicated, it should be given prior to surgery. Next question. There are two radiotherapy options. Long-term course, short-term course, which should be prepared. What is long course? Long course means you should give 25 sitting, 25 fraction, each fraction 2 Cray, totally 50 Cray to be given, it will take 5 weeks. It is indicated when your aim is spindle preservation. That is lower 1/3 cancer, after radiotherapy, it will convert into the anterior resection. In that circumstances or bulky tumor, you go for long course radiotherapy. Your aim is just field sterilization, or for other reason, if you want to give chemoradiation, you may give short course. Short course is nothing but we will give 25 Cray. That means each day 5 Cray. within 5 days, within a week, we completed the RT, then you will do surgery. It is ideal if there is, our aim is not sphincter preservation, our aim is given chemoradiation for sake of the increased survival. We will do given radiotherapy first week, next week we will do surgery. Another point you should know is, if you plant short course RT, when we will do surgery? After RT, you should finish your surgery within a week. Suppose any reason you may not complete your surgery within a week, it can delay it after 6 weeks. Otherwise, first week to 6 weeks, you should not do surgery, even short course RT. In multimodal component, other than radiotherapy, chemotherapy is, what is chemotherapy consideration? Along with the chemoradiation routine, we are given only 2 regimens, that is 5-FU and leucovorin. It is not primary chemotherapy, concurrent in chemoradiation. That is, our chemotherapy will make more sensitized RT to work. One regimen is 5-FU leucovorin, another one is tablet capecitabine. Either one you can select. Capecitabine is oral tablet. It will be suitable for patient with complications and comorbidity. If you give adjuvant chemo, that is, this 5-FU leucovorin given along with the chemotherapy is not real chemo, it is concurrent chemo. After chemoradiation completed, we will give adjuvant chemotherapy if indication present. For that, 2 regimen is FOLFOX and CAPOX. There is 2 standard regimen, you can select any one of them. Multimodal treatment, surgery component, there are 2 surgery, APR and anterior resection, which you will select. That is, your aim is sphincter saving procedure. Try to preserve sphincter without compromising clearance by, if possible, select neoadjuvant chemoradiation. Manually, it is not possible, use stapler and use coloanal anastomosis. Nowadays, modern era, the absolute indication for anterior resection is only 2 conditions. That is, involvement of the sphincter, lower anal sphincter involvement with the rectal incontinence, or extension of the tumor below the tentate line. Both are indication for APR. Otherwise, our plan is to avoid colostomy and do anterior resection. It is a anterior resection by stapler method. And the toe nut, top nut, that is the specimen we should send for pathologist separately. If it is margin negative, it is margin negative. Sometimes the colon become margin positive, the top nut become negative. It is the real margin. Surgery principle, what we should follow. What is APR is, it is en bloc resection of the rectum, anal canal, mesorectum with the draining lymph node and ligating vessels at its origin with the endocolostomy. Anterior resection is nothing but en bloc resection of the rectum, mesorectum with a node without removing the distal rectum with making internal anastomosis. But our surgery, whatever APR, AR, it should be R0 resection. What is R0 resection is, after excising the tumor, there should not be any residual lesion in microscopically with the restoration of the function. Our aim is achieving R0 resection, achieving no colostomy. What are the principles to be followed in rectal cancer surgery is margin, surgical plane, nodal count, ligating artery, its origin. Tumor spillage to be avoided, creasing on the lymph node to be avoided. Margin. How much margin already given? Professors are already told 5 centimeter margin. Before into considering margin, there are 2 margin. Lateral margin, CRM, circumferential radial margin or lateral margin. What this margin indicates is how much you have given clearance laterally. Most of the lymph node dissection comes under lateral margin. Linear margin is nothing but mucosal margin you have given proximally, distally in the rectal cancer. CRM is circumferential radial margin. What it is it between the deepest penetration of the tumor and the edge of the resected soft tissue in the rectum. It should be measured in millimeter. NCCN guideline panel define if it should be more than 1 millimeter. Less than 1 millimeter, it is critical. CRM or lateral margin. There are two components in the margin. What we do lateral dissection is, one is mesorectal excision, another is lymphadenectomy. What is mesorectum? Mesorectum, first described by killed. Killed is the person, our plane, everybody knows, killed, holy plane. That is the plane in the posterior dissection of the rectum, described by killed. It is the cushion of the fatty tissue that surround the rectum posterolaterally. It is covered by membrane called fascia propria, otherwise called tolt fascia. Most of the rectal node situated in the mesorectum. What is total mesorectal excision is, if you do by sharp dissection, the sharp dissection is the word is more meaningful. Your dissection in the posterior plane should be sharp. Whatever method, you can use scissor or diathermy, don't use hand. Every step should be sharp. By meaning sharp dissection, we are achieving two aim. One is total mesorectal excision, another one is preservation of the nerves. Hypocastic nerve preservation is mandatory if you achieved by sharp dissection, remaining the rectum and mesorectum in total. That is, there are two types of mesorectal excision. Total mesorectal excision, that is entirely we will take. Another one is partial mesorectal excision. What is partial mesorectal excision means? Removing the 5 centimeter clearance of the mesorectum lower than lower edge of the tumor. It is indicated in upper rectal cancer. Commonest cause of local recurrence in rectal cancer is poor clearance in mesorectum. So total mesorectal excision, TME, is the size in every cancer, especially middle and lower rectal cancer. If we want partial mesorectal excision, it is indicated in upper third cancer, especially T1, T2. Regarding linear margin, how much you should given? Proximally, it is 5 centimeter. Distally, it is not necessary 5 centimeter clearance. It is the one analysis. Their study shows 2 centimeter is enough. There are contact specimen, only 2.5% of specimen, the lower edge goes beyond 2 centimeter. Remaining 98%, they limited within the 2 centimeter. So distal clearance is 2 centimeter is enough. You need not give 5 centimeter distally. Ultra modern concept is, your aim is try to achieve colostomy free patient. You need not give 2 centimeter. You may give 5 millimeter. Your margin should become as negative. That is our concept. Lymph node dissection, how we will do? There are 4 types of lymph node in colorectal cancer. Tier 1, Tier 2, Tier 3, Tier 4. First tier is epicolic, that is epicolic or pericolic, whatever nodes seen along the colon. Second tier is paracolic. Paracolic means what are the nodes along the named vessels. That is marginal vessels. Third tier is intermediate node along the named branch, right colic, middle colic, left colic. Fourth tier is nodes along the origin of the superior mesenteric artery, inferior mesenteric artery. First 3 nodes, first tier, second tier, third tier to be removed. It is called T3 lymphadenectomy. In stomach we are doing T2 lymphadenectomy. In colon cancer, our aim is all the 3 tiers to be removed. You should understand, even though some node, iliac nodes, external iliac node, internal iliac node, some rectum train into these nodes, it is not recommended unless it is involved. In general, we are taking on the green color, rectal node and mesenteric node we have to remove. Pelvic node need not be dissected. That is, lymph node dissection is mesorectal node, we should go proximally left colic and inferior mesenteric node to be taken. This point explained by Prasad sir. Minimal node we have taken is 12 node. How can we say our surgery is pakka? Your pathologist say your node is only 5. What it indicates is our dissection is compromised one. After doing your surgery, you will say, who will say your surgery is pakka or not is pathologist. He will say resected node is more than 12, that is your surgery is completed one. Finally, what should follow in rectal cancer is mucosal margin above 5 centimeter, below margin should be negative, and proximal clearance, lateral clearance, and mesorectal excision. Anatomical plane. Postgraduate should understand what is plane. Plane is the natural demarcation. If you go in that plane, your dissection also less easy. Most of the blood vessels, neurovascular bundles are in the plane. So if we go in the correct plane, there will be no bleeding. If there is more bleeding, it indicates you are in the wrong plane. In rectal cancer, if you respect the plane, your surgery will be oncologically sound. There are 3 planes in the rectal cancer. I will describe one by one. Plane. Plane 1. Plane 1 is told fascia plane. It is the facial plane which was formed by the fusion of the visceral peritoneum and the parietal peritoneum. It is found between the 2 mesothelial layers that separate the mesocolon from underlying peritoneum. What is plane 1 or told fascia plane is the superiorly there is a colon, blood vessels supplying the colon, all the lymph nodes are this colon. It is covered by fascia called told fascia. Posteriorly, parietal peritoneum. In between, if you go, you will take entire colon along with the draining lymph node. This is between the told fascia and parietal peritoneum. This is the plane between the told fascia and parietal peritoneum. Ureter, all arteries, vein are in the posteriorly. You should lift the colon along with the fascia towards anteriorly. If you go correct plane, any lymph node will not be missed. Second plane is keeled plane. That is the holy plane of rectal surgery. It is in the pelvic cavity, anteriorly told fascia, otherwise called fascia propria. It covers the rectum and mesorectum. Posteriorly, Valdeyer fascia, it covers the sacrum. Your plane should go between the Valdeyer fascia and told fascia. If you go, you will take entire rectum along with the mesorectum with preserving the kyphocystic nerve. What we see is Valdeyer fascia, above is fascia propria. It is the cavity, pelvic cavity. We are living behind the Valdeyer fascia. That is a kyphocystic nerve. This sympathetic component. is a lateral dissection. What you seen is the fascia propria covering the mesorectum. If there is no bleeding, what indicate is your plane is appropriate plane. It is seen, what is mesorectum, just seen like children buttocks. Another plane is anterior plane. Anterior plane, in most of the times in male patient, you may injure prostate. How can we avoid? There should be a natural plane. Here, natural plane, renovular fascia. Renovular fascia present anteriorly. There are two layers, anterior layer, posterior layer. If you go in between, you separate the anterior layer and posterior layer, there should not be a bleeding. There is less chance to injury the prostate. What we seen, what is cleft is the, we are going in between the two layers of the renovular fascia. Here, anterior and posterior layer of the renovular fascia fully recognized. Trick of surgery in rectal cancer is, after surgery, patient should not be impotent. Potential is maintained by the sympathetic and parasympathetic pelvic plexus, so all the nerve to be preserved. Sympathetic nerve is hypocystic nerve from the thoracolumbar segment to the pelvic area. There are two plexus, superior pelvic plexus, inferior pelvic plexus, both are autonomic nerve plexus. Superior pelvic plexus is single one, it is present at sacral promontory, contain the hypocystic nerve. Inferior pelvic plexus are lateral one, lateral side of the pelvic, it is the merge of the parasympathetic and sympathetic nerve. This nerve to be preserved. If you injure the nerve, it will cause impotence in the male, so the nerve should be preserved. Another one is, if you do prayer surgery, first surgery, what indicate? Surgery followed by chemoradiation, the pelvic cavity should be filled by some implant or omentum. After total omentectomy, you keep the omentum in the pelvic cavity. Otherwise, it acts as a cushion. It will not allow the small intestine track down in the pelvic cavity. If you give open, most of the small bowel enter into the pelvic cavity. It will fix it and adherent. After surgery, if you give RT, it will cause small intestine radiation enteritis. So to avoid, you will keep some spacer in the pelvic cavity. Another one is in the rectal cancer, in the anteriorly, there will be some fatty tissue. Your plane is should be between the bladder and fat. Fat belongs to rectum. You should not go in between the fat. It will cause injuries. Operative steps in rectal cancer is, usually we are doing Lloyd David position. First step is lifting the sigmoid mesocolon and incising the posterior peritoneum. Dissection of the ureter and great vessels. Here is the first plane. A plane between the told fascia and the parietal peritoneum, and a ligating inferior mesenteric artery if possible near origin. Next, entering the chole plane, preserve the nerve and mesorectal excision. That is second plane, chole plane. Then lateral dissection, by then anterior dissection. Anterior dissection is the in between two tenular spacia. For descending colon, based on anterior dissection and APR, we will go. Adjacent organ involvement. Postgraduate should know adjacent organ involvement in rectal cancer is not an advanced disease. In cervical cancer or bladder cancer, if adjacent organ is involved, it is stage 4. It is inoperable. But if you take TNM staging, T4 is classified as stage 2. Adjacent organ involvement is T4, but biologically it is curable cancer, it is stage 2. So adjacent organ is involved, still you can operate. It is the rectal cancer with the sacral involvement. We are doing sacral resection along with the anterior resection. This is the photograph. It is a rectal cancer with the bladder, uterus involvement, total pelvic excentrison, both to be done. Metastatic cancer, already discussed by Professor Sundaram and Professor Prasad sir. Generally it is incurable, but still some segment, that is less than 3 liver metastasis, pulmonary metastasis, it is operable. Some nodal involvement is still metastasis. In colon, superior mesenteric node, inferior mesenteric node involved by images or some biopsy, it is, even though nodal disease, it considered as metastatic disease. Rectal, common iliac node involved, it is metastatic disease. Patient even metastasis should be considered for surgical resection, provided patient is fit for surgery, and by doing surgery you can achieve R0 resection. Followed by, for metastatic site also, chemoirradiation to be planned. After surgery, if possible, RT to the lung or chemotherapy to be given. In hepatic liver metastasis, even operable or inoperable, hepatic artery infusional chemotherapy is mandatory. This study shows hepatic artery infusion chemotherapy along with the systemic therapy is superior than only systemic therapy. So if possible, liver metastasis, try to evaluate hepatic artery infusion chemotherapy. Take a message. There are only 2 messages. Being surgeon, don't do direct surgery in all cases. It is better to give chemo radiation followed by surgery. Dear surgeon, don't neglect radiotherapy. Professors are told surgeon is the one of the prognostic factor. Yes, it is proven. 13 studies from all and B Magar specialist surgeon achieved significantly better result than other surgeon in all outcome measures, including size of surgery, TMA and sphincter preservation, adjuvant treatment, local recurrence rate and overall survival. Thank you.
Thank you, sir, for such an great academic experience. Now I request retired Dean sir, Dr. S.M. Kannan sir, to honor our speaker.
Thank you, sirs. For the next session, we would like to invite Dr. Rajashekar sir. Dr. Rajashekar sir has done his MBBS and MS in Stanley Medical College and has pursued in FRCS Ireland, FRCS England and FRCS Edinburgh degrees, and has been an MRCS examiner in the Royal College of Surgeons of Edinburgh. Having done his GI surgical training in South East Scotland, he has been the organizing secretary, TN Pondicherry and Tamil Nadu branch ASICON 2009 and 2016. He has been the past treasurer and the joint secretary in ASI Tamil Nadu and Pondicherry branch. He has also served as the chairman, Salem City branch ASI. He is also the author of 2 chapters in RM Group General Surgical Operations and has been awarded Dr. Vishwanathan Surgeon Par Excellence Award and Dr. Jagannathan Award. He is at present our chairman of Tamil Nadu State Chapter ASI. We are very happy to have you, sir. We take great privilege in welcoming you to deliver the topic on emergency presentation of colorectal malignancy.
Thanks for the nice introduction. Thanks, Professor Alex, for inviting me. Respected BKC sir, GC member of ASI, Dr. Balamurugan, secretary of ASI, seniors, professors, and students. So my topic is emergency presentation of colorectal cancer. So I like visiting the medical colleges because I am not attached to any teaching institute. I am from the private sector. So it always brings back memory. This is my alma mater, Stanley Medical College. It brings back my student days, my examination, just to be on the lighter side. Being a student and going for a final exam is something thrilling, you know. Similarly, I went for the surgical exam in my final MBBS. Our patient on the nalla mabbil erda, that is the patient. In the history, I couldn't elicit, except for being an alcoholic, I couldn't elicit any history from this patient. Say, at least I will do an examination and find some mass or something in the abdomen, this abdominal case. Except for a palpable liver, nothing is there. And diagnosis alcoholic liver disease doesn't fit in a surgical. So can I say something, maybe liver abscess. I decided that I said, okay, that is the only diagnosis I can give. Being an alcoholic with a palpable liver and tender. அப்படின்ட்டு வேத்து இருந்துச்சு. அப்போ அந்த பக்கம் போன அசிஸ்டன்ட் சர்ஜன்ட் சார் கொஞ்சம் தண்ணி கொடுங்க அப்படின்னேன். மழையா இதுக்கு எதுக்குடா தண்ணி கொடுக்குற பேஷண்ட்டுக்கு, இது பைலோரிக் ஸ்டெனோசிஸ் இல்லை, இந்த பேஷண்ட் அமீபிக் லிவர் ஆப்சஸ் டயக்னோசிஸ் அப்படின்னு எனக்கு கன்ஃபார்ம் பண்ணிட்டாரு. Sometimes, you know, the situation helps us. So these memories comes back when I visit the medical college. So what is the extent of the problem in a colorectal cancer? The majority of the time the emergency is either it's going to be a large bowel obstruction or a perforation, which is about 20%. Bleeding is not, massive bleeding is very rare, as all of us know. The common site of obstruction, majority of the time it is distal to the splenic flexure, and perforation, it may be at the tumor site or it may be proximal, which is about 30%. So what is the goal as a surgeon when we come across a colorectal emergency? One is the immediate negative impacts of the complication like sepsis. If the patient with obstruction or a perforation comes, the first major problem is the sepsis. And then we have to tackle the tumor and give a better result, tumor control or oncological dissection of the tumor as well. And then ensure timely recovery to permit the post-operative treatment like adjuvant systemic treatment, which Dr. Bala and BKC have mentioned. So we have the three different roles. One is the emergency. We have to take care of the emergency situation. We have to give an oncological cure for this patient if possible, and then prepare the patient for the future therapy. So the bleeding, any GI bleeding, the first and foremost is a resuscitation, and then we need to localize and then control. So there are different modalities for this. One is a radionuclide scanning, which will tell you where it comes from, but it cannot control. Whereas a selective mesenteric angiogram, it can tell you where the bleeding is, like a blush here, what you can see, that is a blush where the arrow is pointing. That means it's bleeding there. The advantage is you can embolize this site bleeding and then control and then plan electively for surgery. So that is the advantage. So that becomes the gold standard. Colonoscopy, again, the yield is very difficult. You can't prepare blood in the colon. You may not be able to localize the tumor in the bleeding site. And surgical resection is going to be blind and it is not worth it. In the modern era, when facilities are available for angiography, that is the method of controlling the bleeding. Obstruction, again, you need to have a high index of obstruction, and clinically you will be able to diagnose the obstruction. If it is a low rectal tumor, just by putting your finger, like Bailey says, if you don't put your finger, you have to put your foot into the rectum.
So all the patients with obstruction is always better to put in a finger and make sure there is no tumor, or when you see the ballooning of the rectum, it means there is some obstruction above. So do that. Simple x-rays, we all do x-ray. Is it very much beneficial? It can tell you where the obstruction is, but it will not tell you what the pathology is. Ultrasound gives better information. It can localize the tumor. It can tell us about the metastatic status and also local complications like free fluid or a perforation, etc. However, CT gives much more valid information. So that becomes the standard. In emergency, again, a water-soluble contrast enema may not be technically feasible. However, under perforation, if the patient has got, again, it's going to be a problem. Colonoscopy, again, preparation of the bowel and going in, but sometimes in obstruction, you can put in a colonoscope to see where the tumor is. So the standard X-ray, we know that, and the ultrasound, again, it can show the tumor, where the tumor is, and the dilated bowel, etc. Whereas the CT can tell you where the tumor is, and the proximal dilatation, loaded cecum. And also it can show local complications that the tumor is perforated and presenting as a localized abscess, or a perforation with, you can see some free fluid around the cecum, and also a retroperitoneal abscess in the retrocecal abscess. This may be misinterpreted as a perforated, appendicular abscess. That does happen. So one should be careful, particularly in a high-risk patient, elderly patient, when they present with a retroperitoneal cecal abscess. It could be a tumor in the cecum or the appendix, so should be cautious. And then sometimes the patient can present with a intersusception, any tumor or a polyp they may present. That's a target sign which is being shown where there's a lumen and the intersusception, everything is there. Now the colonoscopy in an emergency sitting, if you think with the X-ray and ultrasound and the CT, there's a distal obstruction, then you can pass in a colonoscope and you can see the tumor there. Once you see the tumor, you can take a biopsy and come out. Sometimes in an emergency setting, when you open up, if the patient is unstable, you may not be able to do a resection, you're going to do a bypass, you won't have a tissue diagnosis. At least you can see that the tumor is a large tumor obstructing. So again, they were talking about synchronous malignancy. Here is a colonoscope. That is a tumor in the left side. Somewhere you can see a large tumor. So always any patient, this is an elective case. Look at the age. It's a 33-year-old female presenting with a bleeding per rectum and putting in a scope, seeing, and it's a large tumor. I'm having difficulty passing beyond the tumor, getting to the proximal colon. With difficulty I passed in. Now I passed in, I think. So colonoscopy becomes very mandatory in any patient when you suspect a colorectal cancer, because significant, about 3 to 5% of the patients do have a synchronous malignancy. Some patients will have multiple polyps. So the decision making will definitely depend. You can see that that's a second tumor in somewhere in the transverse colon. So 33-year, she had 2 tumors. This is a synchronous tumor. So this is common. The problem in an emergency when you operate without a CT scan is you may be missing a synchronous tumor and doing an inappropriate surgical resection. The perforation, again, you can have an X-ray to confirm free air. Ultrasound again can tell you there is a perforation, collection, free fluid, etc. However, a CT is much better to give you more detail about the localization, the extent of the problem, extent of the peritonitis, and as water-soluble contrast enema. If the patient is sick and you can't detect the distal, maybe rectal perforation, it may be worth it. And colonoscopy, again, it's going to be a problem because of the air you're putting inside the colon, and the unprepared colon is not advisable. So the best thing is, once a patient is stable and you think the patient has got a perforation of the colon, best thing is to get a CT scan before proceeding further, because you might be missing a lot of information. CT, it confirms, it tells about the stage of the disease and the site of the disease, And then sometimes you might be able to plan for a conservative management. If it is a very small loculated collection, you can conservatively manage with antibiotics, prepare the patient and then take the patient electively so that the results are much, much better. Surgeon can foresee what sort of an operation I'm going to do with a CT scan rather than going blindly in the middle of the night, opening up an emergency perforated colorectal cancer and blinking what to do. At least you will have a clear vision whether I need a help, what are the accessories I need, what the staplers, do I have a stapler to anastomose in case there is a difficulty. So the proximal perforation can happen and the patient can present with peritonitis. The primary aim in a patient presenting with the perforation is a damage control surgery. That is your primary aim. Sepsis, you have to control, the source control. So in case of a right, we can do a resection anastomosis if the contamination is good. As Dr. Bala and BKC said, it's the surgeon's experience matters whether he goes for a primary anastomosis or not. You can do a resection, ileostomy and bring the distal end as a fecal fistula, or a loop ileostomy in advanced cases or a moribund condition where you just want to buy time. You can do a loop ileostomy. On the left side, you can resect and bring a colostomy Hartmann's procedure, or in a palliative case, sometimes you just do a transverse colostomy. Here is a patient who was presented with peritonitis and in a moribund condition was brought in a ventilatory support. You can see that is a total proximal cecum is completely blown out with perforation, the right resection. This, and on opening up the specimen, you can see, even I couldn't feel the tumor actually. When there is a tumor, that is in the ascending colon, because of the competent ileocecal valve, the cecum is blown up and peritonitis. And this patient, again, I couldn't pull, wondering what to do, did a primary anastomosis and managed, this was about 18 years back, and did a open abdomen because the patient, when I operated in a moribund state on a ventilator, inotropic support, and then secondary closure of the abdomen was done. Luckily, he is alive till today. This patient's age was again 32 years. When he presented as an emergency, we wouldn't have suspected. CT was not done. In the middle of the night in a ventilator patient, getting him to the CT scan was difficult. So CT was not done. Maybe CT, if I had done, I would have known the patient has got a tumor there. And I mean, now, today, it won't be inappropriate to do surgery without a CT. Another patient presenting with perforation clinically, you can see you have to take a pus for culture sensitivity like any perforation, know what is the organism and the sensitivity that is being done, and you can see there is a perforation in this sort of a hepatic flexure. It's a tumor site perforation. There is a nodule there in the omentum. So that more looks like a metastatic nodule, and that is a tumor, and that is a tumor site perforation. Then this being a right side, can go ahead and do a resection and anastomosis, and you are not comfortable with anastomosing, you can do a ileostomy and then a fistula, distal mucus fistula can be done. Doing an anastomosis in the right side and bringing in a diverting loop ileostomy, majority of the time, it's not advisable, and the results, a lot of studies have shown that that does not decrease morbidity and mortality by diverting or the anastomotic leak. Rather, many patients land up with the ileostomy, they don't come back for closure of the ileostomy. So they do live with a ileostomy. That is what the problem. So right side, if at all possible, you can just go ahead, resect and do an anastomosis. Dr. BKC said the technique, whatever you are comfortable. I am comfortable with the single layer interrupted 4-0 PDS, 0 submucosal. This is known as Aberdeen technique. 4-0 interrupted for the left side. Right side, I do a continuous single layer 0 submucosal 4-0 PDS. Several studies have shown that the 4-0 material, or even some use 5-0, has given a better results and the anastomotic leak. But at the end of the day, it's the surgeon's experience and the technique, and without any tension and the vascularity of the bowel which matters. So this is another tumor opened up. This is resected and the end-to-end anastomosis was done. Always examine the specimen as a surgeon, just don't resect and come out. So once you have to open up and see the specimen where the perforation is. This particular patient, elderly patient, so I'm just bringing it as a ileostomy rather than a primary anastomosis, because again he was in septic shock. So another patient with a loculated at the site perforation, that is the hepatic flexure. You can see the tumor with a loculated collection abscess and been resected, specimen open, named. Ideal way of sending a specimen to the pathologist is you have to name the parts, different part. They should know what part is what, proximal or distal, pin it and send it, then you get a better result. Sometimes you don't do that, you don't know whether the resection margin, proximal or distal, how many millimeters or centimeters is there. So another patient, again a young patient, 33, been suffering with constipation, running pillar to post, not diagnosed, a coloscope was not put in, presenting as an emergency, and you can see it's a tumor perforation, sigmoid colon perforation, which was missed. So Hartmann's was done, removed and done. So here a suspected case of appendicitis. So a laparoscope was done. We have done an ultrasound, not a CT, because with the ultrasound findings of appendicitis, we go ahead. There's some sort of a mucus or a pus was there. Opened up, mobilized the appendix, it was stuck together, and with a blunt dissection the appendix was mobilized and appendicectomy was done. One of the reasons for sending the appendix for routine histology is sometimes you may come up with a unusual diagnosis, like this patient had a malignancy of the appendix, mucinous carcinoma, adenocarcinoma of the appendix. So this patient has to be brought in for a definitive surgery. So appendix, that is why some of the patients with a cecal tumor or right-sided tumor can present with an obstructive appendicitis. So don't just treat the appendix and send for the specimen. You should be very cautious. A CT will be helpful. So coming to the obstruction, it is always an individualized treatment. There are several treatments available, where it depends upon what is the age of the patient, what is the comorbid condition of the patient, whether what about the obstruction, and what are the therapeutic resources available, and what is your experience of managing these cases. That's what matters. The left-sided, if the patient has got a curative tumor, you've diagnosed obstruction, you've got a CT done, though no metastasis, and you know where it is, then you can go ahead, do a primary resection anastomosis without diverting stoma. Again the stoma following anterior resection, some do a transverse colostomy, some do a loop ileostomy. I always do a loop ileostomy because it's easier to perform as well as close. And the Hartmann's procedure may be, depending upon the condition of the patient, you be safe, remove, do a stoma and come out, and then self-expanding metal stent followed by a definitive surgery. This is known as a bridge to surgery. Suppose the patient has got obstructive lesion and you have facilities to put in a stent inside, you can put in a stent and then by time, prepare the patient and then take the patient electively for surgery. However, studies have shown there's not much of a difference in the morbidity, mortality of the cancer thing. Only difference is the patients having a bridge to surgery, having put in a stent and then followed by surgery, the incidence of creating a stoma had come down. That is what they believe. So in a nutshell, this gives a good treatment plan, a stenting whenever the facilities are available, expertise are there, because sometimes stenting is also associated with complications like perforation, migration, etc. So it lowers the colostomy rate and lower mortality. Or you can do a one-stage resection in low-risk patients, and here the advantage is no need of a colostomy, and only concern is a anastomotic dehiscence. So intraoperative colonic irrigation, again whether we should do a colonic irrigation, but studies have shown that intraoperative colonic lavage is cumbersome and it doesn't have any added advantage. That's what it says. No evidence that it is necessary. Whereas you can manually evacuate the colon with a control, whereas the other one is a cumbersome procedure. Subtotal colectomy is indicated in certain instances where there is a proximal perforation, or there is a synchronous tumor, or there is a ischemic bowel. Then you can go ahead do a subtotal colectomy. Or Hartmann's, in high-risk patient, it's a safe procedure. And simple colostomy is indicated only in a palliative setup where the patient has got a metastatic tumor with a perforation, peritonitis. Then you go for a palliative colostomy, otherwise don't do it. Even then, if it's obstruction, if you can insert, somebody can insert a stent, better refer the patient there rather than giving a patient a colostomy. So total colectomy, segmental, segmental is okay, but sometimes if the patient having a synchronous tumor with a proximal perforation, should we remove the entire colon? But studies have shown that you remove the entire colon even in synchronous, it doesn't reduce the morbidity, mortality. That's again our gray area in synchronous tumor when patient having a right-sided colonic tumor and the left-sided colonic tumor. What should we do? May I ask that BKC sir? It's always a gray area. I don't know what to do. I've come across 3 patients. One had a left side, there is a low rectosigmoid tumor. Another is on the right side. Will you do a right heavy colectomy, anterior resection, preserve the rest of the colon?
As yourself has correctly told, it's a gray area. Even if you do a total colectomy and do a iliorectal anastomosis, people say, what will you do for the rectal recurrence? If you do the ilio-anal anastomosis, then we'll say what you do for the anal recurrence. So some people go for a total proctocolectomy and a permanent ileostomy. And if it is suppose there is only one lesion on the right side and there is another synchronous lesion on the left side, definitely a right hemicolectomy with a segmental resection on the left side will carry as good result as that of the total colectomy. Because as you said, you cannot avoid recurrence or new lesion in the remaining colon or remaining rectum, and the complications of colectomy, the morbidity, the frequent diarrhea is also to be taken care of.
Exactly, sir. Bowel decompression I have already mentioned, so you can do instead of a colonic irrigation, you can do a versus manual decompression. This is a prospective randomized trial comparing intraoperative colonic irrigation with manual decompression, and the conclusion is manual decompression of the proximal colon without irrigation is as safe as a colonic irrigation in one-stage surgical management of obstructing left-sided colorectal cancer. So sometimes, the preparation and, if the colon is so much distended, definitely we need to decompress, otherwise we cannot do a anastomosis, so much distended with a competent ileocecal wall. Then on the safer side, this patient underwent resection and a Hartmann's procedure. So it's so difficult, the distended ball. So right side is slightly less complicated than the left side. Right colectomy with the primary anastomosis, majority of the cases you can do when it is obstructed. A terminal ileostomy associated with the colonic fistula in very selected high-risk patients where you suspect it's going to cause a problem. Sometimes patient may present with, this patient presented with intestinal obstruction on the right side, and you can see that's an intersusception. So intersusception could not be reduced. So in adults, for the postgraduates, in adults, when there is an intersusception, there is definitely a pathology there. There may be a polyp, a tumor, or some pathology which is sitting there causing the intersusception, unlike the children where you can decompress, without surgery. Whereas in adults, majority of the time, there is a pathology there. There, a resection was done and end-to-end anastomosis was done. There's a single layer because I said right side. I do a serous submucosal. I don't take the mucosa, only the serous submucosa which has got the strength, leave the mucosa without a suture. So on opening up, even on the specimen, on opening up it was so difficult, and there is some pathology, there's like a polypoidal growth there. That's it. That is what has caused the intersusception. Another patient got a CT here. On the CT, you can see this is the target sign there. Here. These pictures. and that is an interception, ileocolic interception, ileum and the colon, and resected, and end to anastomosis, again serosubmucosal anastomosis was done. You can see that is the specimen. On closer look, you can see the tumor there. So this is a cecal tumor presenting as an interception. So these are all possibilities in an emergency presentation. Another patient presenting as a classical small bowel obstruction. Majority of the time when we do a small bowel obstruction, is a clinical diagnosis, you do an X-ray and the patient is not settling, you go ahead. Whereas here the tumor was, small bowel was stuck to the rectal cancer, so it was presenting as a small bowel obstruction. So here a concomitant resection of the small bowel along with the rectal tumor was done, and that is the small bowel was anastomosed, and the rectum I think I did Hartmann's, and then with a drain came out on the safer side, and the specimen again were opened up. This is after separating, that small bowel is in the other side, and that is in toto, the small bowel along with the anterior resection of the rectum. So this is what is the palliation of a stenting procedure. I've told stenting should be preferred to colostomy for palliation if the facilities are available. So colonic stenting as a bridge to surgery versus emergency surgery for malignant colonic obstruction. This is a multi-center randomized controlled trial, and they conclude that it should be done in a center of excellence in expert hands. One. Another is a meta-analysis, colonic stents for malignant bowel obstruction, current status and future prospect is a best procedure, best palliation by avoiding but substantial concerns of tumor seeding following SEMS placement, especially in case of perforation, have been raised in numerous studies. So it is not indicated in perforation. There is no significant difference or reported in oncological long-term survival between patients undergoing stent placement and those undergoing emergency surgery. There is no difference. Considering the above mentioned factors, colonic stenting should be evaluated only in highly specialized centers with expertise. So ladies and gentlemen, in a nutshell, when the patient is presenting with an obstruction, if it is a right-sided curative, go ahead, resect, do a primary anastomosis. In a high-risk patient, maybe you can think of a covering ileostomy, but I would say go for a primary anastomosis. If the patient is unstable, then you can do a right colectomy and do a ileostomy or a loop ileostomy depending upon the situation. And if it is curative, and then the right colectomy with anastomosis. That's what I said. Left-sided, again, if the patient is unstable, then you have to do source control and do a Hartmann's procedure, and then you can do a Hartmann's procedure, or you can do a transverse loop colostomy as a palliation. If it is curative, you can go ahead do a primary resection and anastomosis or a Hartmann's procedure, or if facilities are available, you can put in a stent and then take the patient electively once the obstruction is relieved and the patient is in a better condition for surgery. When there is an extraperitoneal rectal cancer, then it becomes a palliation, then you do a diversion, either a colostomy or a ileostomy, and then subject the patient for a new adjuvant chemoradiotherapy. In case of a perforation, the first primary goal is a sepsis control, damage control surgery, and if the patient is stable, yes, all the tumor, when the perforation is the tumor site, then you can go do an oncological resection, and then you can do a primary anastomosis and bring in a stoma. Or when it is in the proximal tumor, as we have told, you can go ahead do a subtotal, or if it is on the left side and the right side, you tackle the left side tumor. If the perforation is the right side, you tackle that perforation separately. And then this all permutation combination, this you have to decide with the help of your investigation, the patient's condition, the facilities available, and your expertise in OT. So for the postgraduates, this is a World Society of Emergency Surgery guidelines on the management of a colorectal care emergencies. This gives all the details. If you read this article, this gives all the information, whatever I have told. So you can read that in the World Journal of Emergency Surgery. You can download and read it. With that, I thank you all for the opportunity. Thank you.
Thank you, sir, for such an enlightening and knowledge-bubbling speech. So, yes, sir.
This is a comment to Rajshekar's lecture. Instead of giving topics like that, talking with the demonstration is really good and it gets into our mind deeply rather than pure lectures. Number one. Number two, he emphasized many important points just like that for the benefit of the postgraduates. One is a mechanical bowel irrigation and all these things is not superior to just emptying the loaded fecal material. Because I have passed the era of bowel irrigation. When the loaded bowel, there will be one person will put a pursing and put a tube into the cecum and then inject saline and will empty it out. All these things have not worked. Just to empty fecal with the kidney tray and do anastomosis with the perfect anastomosis, the importance of the surgeons and his expertise. That is very important point to remember. All these bowel irrigation that don't serve any purpose. And another important message told anything including the appendix, once you remove, though it is ultrasonography appendix, don't throw it off, always send it for a biopsy because you may get a surprise. And another point you are insisting that is the total colectomy is not very much a beneficial surgery, and ileostomy is better, easier to do as well as to close. That is very important. Colostomy also easier to do, but difficult to close. Whereas ileostomy is easy to close and do it and close. And finally, thanks for the information of the World Journal of Emergency Surgery, which it is new to me. Thank you very much.
Thank you. Thank you.
Thank you, sir. As a token of our gratitude, we now request Dr. Pratap Nanamuthu sir to honor the speaker, Dr. Rajashekar sir. Thank you, sirs. Esteemed dignitaries, our beloved Dean sir is on his way for the inauguration of the seminar hall. So, we'll resume the inaugural function shortly. Esteemed guests, we have with us our beloved Dean, Dr. Ravichandran sir, inaugurating the Surgery Seminar Hall, Dr. M. Tangaraj Seminar Hall. Let's give a big hand. Thank you, sir. It's time for us to start the inauguration function. So I request the dignitaries to occupy the dais. First I invite our Dean, First I invite our respected Dean, Dr. Ravichandran sir, to occupy the dais. I request our Vice Principal, Dr. Shantaram sir, to occupy the dais. I request Dr. Rajashekar sir, Chairman, Tamil Nadu ASI chapter, to occupy the dais. I request Dr. Balamurugan sir, Honorary Secretary, Tamil Nadu ASI chapter, to occupy the dais. I request Dr. Kannan sir, President, ASI Tirunelveli City Branch, Dean, Mookambika Institute of Medical Sciences, to occupy the dais. I request Dr. Jailal sir, Professor, Department of General Surgery, President, IMA, to occupy the dais. I request Professor Dr. Alex sir, HOD, Department of General Surgery, to occupy the dais. I request Dr. Balasubramaniam sir, Medical Superintendent, Tirunelveli Medical College, to occupy the dais. I request Dr. BKC Mohan Prasad sir, to occupy the dais. Thank you, dignitaries. I request everyone to rise up for Tamil Thai Valtu. Thank you, everyone. Please be seated. I cordially invite you one and all for the CME Coloclash 2021. I now request our respected Sir, Dr. Kannan Sir, President, ASI Tirunelveli City Branch, Dean of Institute of Mookambika Medical Sciences, to deliver the welcome address.
Respected dignitaries, distinguished guests, my dear friends and young budding surgeons, good morning to all. It's great pleasure to welcome you all for the Coloclash 2021. Before welcoming you all, first I would like to render my gratitude towards my teachers, Professor Tangaraj sir, Professor Muthukrishnan sir, Professor Gomanayam sir, Professor Pandian sir. They are all my teachers. They taught me surgery and so many things beyond surgery during my studies.
I am here because of them only. Thank you for all. First of all, I welcome our beloved Dean, Professor Ravichandran sir. In spite of his busy schedule, he has guided us and given permission to conduct this CME and properly given all support for this. I welcome you all for the CME, sir. Second, I welcome Professor Dr. Rajashekharan sir, Chairman, Tamil Nadu Pondicherry Chapter of Association of Surgeons India, who has taken much pain to come over here from Chellam to Tirunelveli for the CME. I welcome you, sir. I welcome Professor Jayalal, National President of IMA, who has consented over here to deliver the guest of honor address for this CME. I welcome you, sir. I welcome Dr. Balamurugan sir, our Secretary, Tamil Nadu Chapter, Pondicherry Chapter of ASI, who has taken much pain and interest for this CME, who has guided us for conducting the CME very well. I welcome you, sir. I welcome Dr. Mohan Prasad sir, who has taken much pain to come over here for the CME. I welcome Vice Principal Dr. Santaraman. I welcome Dr. Balasubramanian, Medical Superintendent of this hospital. I welcome all the faculties of this college and postgraduate students. Thank you, and once again I welcome you all for the CME. Thank you very much for the opportunity.
Thank you, sir. Now, I request the dignitaries to light the Kuttu Vilak. Thank you, dignitaries. It's now time for us to honor the esteemed guests on the dais. I first request Dr. Alex sir, HOD, Department of General Surgery, to honor our beloved Dean, Dr. Ravichandran sir. I now request our beloved Dean, Dr. Kannan sir, to honor Dr. Rajashekar sir, President, Tamil Nadu ASI chapter. Thank you, sir. I now request our Dean sir to honor Dr. Balamurugan sir, Secretary, Tamil Nadu ASI branch. Thank you, sir. I now request Dr. Ismail sir to honor Dr. Kannan sir, President, Tirunelveli City Branch, ASI. Thank you, sir. I now request Dr. Gopinathan sir to honor Dr. BKC Mohan Prasad sir.
Sir, I am also a first class madam Ismail.
Thank you, sir. I now request Dr. Tangaya sir to honor Dr. Jailal sir. Thank you, sir. I now request Dr. Balaji sir to honor our medical superintendent, Dr. Balasubramaniam sir. I now request Dr. Paulus Prakash sir to honor Dr. Alex sir. Sorry, I now request Dr. Parimalam ma'am to honor Dr. Alex Arthur Edwards sir.
Dr. Alex is my younger brother. He deserves many applause. Being a president or chairman of ASI Tirunelveli chapter, if I want to think to execute something in my mind, Alex will execute it immediately. Before telling to somebody else, he will execute everything. He is man of action. Because when we were PG students, our Professor Tangaraya sir hosted the conference, Tamil Nadu Pondicherry Chapter Conference in Tirunelveli. When I took over as chairman, I told him, Alex, you remember those days, Tamil Nadu Chapter Pondicherry Conference was conducted here. Why didn't you conduct this conference in our tenure in Tirunelveli? He successfully conducted in Kuttalam, his man of action. Good applause to him. Thank you very much.
I now invite our beloved Dean Sir, Dr. Ravichandran Sir, to deliver the inaugural address.
Respected teachers, respected ASI associates, and my close friend Dean Dr. Kannan Sir, Dr. Alex, HOD of Surgery, and my colleagues, good morning to all. I am almost speechless to attend this function because after a long time I am meeting all my teachers who have taught surgery with dedication and all. Without them, I would not be a doctor at all. So I should thank Dr. Alex for giving me an opportunity to meet all my teachers. Thank you, sir. And the second thing is the dedication by Dr. Alex, sir. You might be knowing it. This is a COVID pandemic, and in some of the districts still the pandemic is going on, and the surgery department work, everything is severely affected. They are not able to maintain the departmental work. In the amidst, in our hospital, the surgery work is done excellently by our Dr. Alex. This was never affected, and the surgical procedures and innovative surgeries were done with great difficulty. Of course, he could carry all the work without much difficulty, even with the participation of COVID and all. And a blessing in disguise is utilizing the COVID. He has renovated the entire department of surgery, never seen before in the history of TVMCH. It's a great applause to him. Give him a big hand. You might have noticed the dramatic difference in the department of surgery, and the department of surgery is renovated far beyond the level of, even I can call it as a MMC. The door, the faculty's room, HOD's room, everything is revamped to the top-notch level. And he is also going to construct 2 new modular theatres for surgery. This is on the cards. So our department of surgery will be in the top class in the state very soon. All these credits goes to our HOD, Dr. Alex sir. So this conference is also in commemoration to give him a thankful and applause to Dr. Alex. So everybody should keep his hands strengthy, and our department should grow more and more. And I wish the function great success. Thank you.
Thank you very much, sir. I now request Dr. Gopinathan sir, the dignitaries, and Dr. Pratap Nanamuthu sir to inaugurate the Skills Lab. Thank you, dignitaries. Professor Dr. Muthukrishnan Sir's library will be inaugurated by Dr. Muthukrishnan Sir at the end of the inauguration ceremony. Thank you, sirs. I now kindly invite our chief guest, Dr. Rajashekar Sir, President, ASI Tamil Nadu Chapter, to deliver his address towards the gathering.
Good morning to all. Respected Dean, Dr. Jayalal, IMA National President, Dr. BKC Mohan Prasad, GC member of National ASI, Dr. Balamurugan, Secretary of ASI Tamil Nadu Chapter, and the rest of the dignitaries on the dais, It gives an immense pleasure to be here, to see a lot of activities being going on in Tirunelveli. Just now we inaugurated the skills lab. It doesn't look like a government hospital having a skills lab. It looks like more like a private. I have visited many centers in US and UK and Europe. It's been happening in Tirunelveli. All the credit goes to the entire team led by Dr. Alex. It's no wonder Alex is very popular getting claps in Tirunelveli. He is getting claps in Salem. He came for the PG clinic, that half a day he grilled the PGs, but the end of the day they benefited. Everyone keeps talking about Alex and they want us to bring him back for the PG clinics, which we'll be doing. And first information I want to give is Pondicherry has bifurcated from us. So I was telling about Pondicherry. So they voluntarily bifurcated from Tamil Nadu. So Pondicherry is a separate state chapter. We are only Tamil Nadu state chapter for the information. And having taken over as Tamil Nadu chairman only last month, we organized a program for which I thank the entire Tirunelveli team who had come all the way up. They took part in the clinics and CME and the installation program. And I thank also Alex to release the first e-journal. Dr. E-journal was released during the installation meeting, and he's promised to give us a quality journal, I think, with the help of all. So he'll be bringing a quality journal next 3 editions. So we'll have some 4 good journals material. So I always believe in teamwork, and I have given each of my office bearers a dedicated work. So we have one responsible for the PGs, one responsible for UGs, one for the practicing surgeons, one for developing the skill, one for membership, etc. So all of them are working together, and the ringmaster is Balamurugan. He's not for all, he's a ringmaster for me. He's always chasing me. Are you communicating with the office bearers? Are they doing all the work properly? So he's a ringmaster for me. So with a good team and a secretary like Balamurugan, I think we can do good work. Like Alex being here, we can do good work. So we have a lot of programs in the pipeline. The PG program, which is going to be a Zoom program, is going to start this month, as well as the undergraduate, because the undergraduates are being ignored in many of the places. That's why in Salem for 5 to 6 years I had been organizing a one-day CME for the benefit of the undergraduate program. That's what we call it as a surgical download, because most of the time it's the PGs we are concentrating. We have to teach the undergraduate as well. So we did have a model of few common lectures, and the clinical examination was done by the students, and the examiners were examining, and it was conducted just like a real exam and giving marks, so that they'll have a feedback where they went wrong and how to answer, etc. So that PG undergraduate program also we are starting. We have tied up with Johnson & Johnson, looking at the lab here. I think Alex can do a wonderful laparoscopic training program here in Tirunelveli. So we have tied up with J&J. They are going to concentrate both on the PGs as well as the practicing surgeon. The modules we are working. Because of the COVID, it's going to take a couple of months. I think the next meeting, maybe in a month's time, we'll be doing in Zoom. And then this I'm planning to do in each of the branches. And then a live laparoscopic workshop and a laparotomy. We all talk about laparoscopy. but we forget about the common thing of a laparotomy. We have to teach all our students how to do a proper laparotomy and how to do the procedures open, because they land up with a complication during laparoscopy. If they don't know to do a open procedure, they'll land up with a problem. So what are the problems associated with laparotomies, how to manage, selecting the suture material? We have a module for that. So we have the pipeline, again the same thing for the surgeons as well, practicing surgeons. It's all a practical module which will benefit. So I request all your cooperation so that we all learn together, learn from each other and move forward. I congratulate the entire Tirunelveli team for organizing an excellent workshop. It deserve a standing applause for them, ovation. Can we all stand and give a applause for the entire team? For நீங்களா உட்காருங்க, திருநெல்வேலி டீம் நீங்க உட்காருங்க, நீங்க உட்காருங்க. Great. So I congratulate and thank each and everyone. They have an excellent team. They come with innovations like the video. The video for the Kutralam meeting was a highlight. Till I remember I saved it. That was very good idea and implemented. I was wondering where the video is for this conference, and suddenly it was released yesterday, day before. Trailer was released. And the original picture is much more better than the trailer. Thanks to the entire team and wish you all the best. Thank you.
Thank you very much, sir. I now request Dr. Balamurugan sir, Honorary Secretary, Tamil Nadu ASI chapter, to address the gathering.
Good morning to all. பைபிளில் சொல்லுவாங்க, நீங்கள் எல்லாம் பாக்கியவான்கள். அதே மாதிரி திருநெல்வேலியில் போஸ்ட் கிராஜுவேட் படிக்கிறவங்க எல்லா பேருமே பாக்கியவான்கள். ஏன்னா உங்களுக்கு பல பேருக்கு ஒரு விசினரி வேணும். பிஜி படிக்கிறப்ப தான் நம்ம மைண்டு சிந்திக்க தொடங்கும். நம்ம எப்படி ஃபீச்சர் பிளாட்ஃபார்ம் எப்படி கிரியேட் பண்ணுறது, அதுக்கு ரோல் மாடல் இங்கே உங்கள் பக்கத்திலே இருக்காங்க. இப்போ அவர் நேஷனல் பிரசிடென்ட் ஜெயலலிதா சார், அவர் ஒரு ரோல் மாடல். இப்போ ட்ரிங்க்ஸ் சாப்பிட்றவங்க, தண்ணி அடிக்கிறவங்க அவங்களுக்கு இம்பார்ட்டன்ட் அந்த மிக்ஸ் கரெக்டாக இருக்கணும். எப்படி மிக்ஸ் பண்ணோம் அது கரெக்டாக இருக்கப்போ தான் அவங்களால என்ஜாய் பண்ண முடியும். அது மாதிரி அஸ் டாக்டர், அஸ் சர்ஜன், நமக்கு ப்ரொஃபஷனல் லைஃப் ஒன்று இருக்கு, அதுபோக அசோசியேஷன் லைஃப் ஒன்று இருக்கு, அதுபோக ப்ராக்டிஸ் இருக்கு, டீச்சிங் இருக்கு. இதை கரெக்டாக மிக்ஸ் பண்ணவங்க யாருன்னு பார்க்குறப்ப தமிழ்நாடு, இந்தியாவிலேயே ஜெயலலிதா சாரை சொல்லலாம். மிக்சிங் இந்த லைஃப்ல மிக்ஸ் பண்றத நான் சொல்றேன். ஏன்னா சில பேர் ஒன்லி டீச்சிங்ல இருப்பாங்க, அடுத்ததுக்கு போக மாட்டாங்க. சார் பெஸ்ட் டீச்சரா இருக்காரு. அது மாதிரி அசோசியேஷன்னா அவர் நம்பர் 1 இன் இந்தியா, நேஷனல் பிரசிடென்ட் ஆஃப் இந்தியா. அதாவது திருநெல்வேலி சவுத்துல இருந்து காலையில் கூட சார் சொன்னார், எப்படி இவர் வர்றாரு, எங்களுக்கெல்லாம் அந்த பாலிடிக்ஸ்ல போக முடியல, பாலிடிக்ஸை எப்படி அனலைஸ் பண்ணி அதை டைஜஸ்ட் பண்ணி அதை ஓவர் கம் பண்ணுறதுல தான் அசோசியேஷனில் டேலண்ட் இருக்கு. அது சார் நல்லா பண்ணுறாங்க. அது மாதிரி சார் பெஸ்ட் ஒரேட்டர். அவர் நான் அவர் மீட்டிங் எல்லாம் போய் அவர் பேச்சை கேட்காம வெளியே வர மாட்டேன். அந்த அளவுக்கு அவருடைய ஸ்பீச் ஸ்டிமுலஸ் ஆகும், அட்ராக்டிவாகவும் இருக்கு. நான் அப்படி கேட்டுட்டு ரசிச்சுக்கிட்டு இருக்கப்ப அடுத்து நான் ஒரு ஃபங்க்ஷனில் போகிறப்ப அங்கே ஹெல்த் மினிஸ்டர் பேசுறாரு. அவரும் இதே வார்த்தையை சொல்றாரு, ஜெயலலிதா பேச்சை நான் கேட்காம எங்கேயுமே போக மாட்டேன் அப்படின்றாரு. நமக்கு ஊக்கமாக தைரியமாக கொடுக்குற அந்த ஸ்பீச் அவர்கிட்ட இருக்கு. அது போக அவருடைய ஆளுமை திறன், பர்சனாலிட்டி, கமாண்டிங் கெப்பாசிட்டி. நேற்று ஒரு ஜூம் மீட்டிங் அவரோட இருந்தோம், ஹாஸ்பிட்டல் போர்ட் ஆஃப் இந்தியா. சார் அது ஓரளவு இருக்கு, அதை ரிவார்ம் பண்ணி நல்லா கொண்டு வரணும்னு நினைக்கிறாங்க. சில பேர் சொன்னாங்க, நான் நெக்ஸ்ட் மந்த்லாம் கிடையாது, இன்னைக்கே பண்ணுங்க அப்படின்னு சொல்லி அவர் ஒரு கமாண்டிங்கை கொண்டு வராரு. அது நீங்க ஐ ரிக்வெஸ்ட் ஆல் பிஜி டு மேக் ஏ ரோல் மாடல், ஜெயலலிதா ஏ ரோல் மாடல். அது மாதிரி அலெக்ஸ் அடுத்தவர், அவரும் ஒரு டைனமிக் பர்சனாலிட்டி. அது லீடர்ஷிப் இஸ் ஆக்ஷன், நாட் ஏ பொசிஷன். அவர் எப்பயுமே ஆக்ஷன்லேயே இருப்பார். அவருடைய ஆக்டிவிட்டி குற்றாலம் கான்ஃபரன்ஸில் பார்த்தோம். இப்போ எங்கள் சேர்மன் ராசகர் சொன்னார், எங்கள் ஏஎஸ்ஐ ஆக்டிவிட்டிஸை ஒரு 5ஆக பிரிச்சிருக்கோம். அகடமிக் ஆக்டிவிட்டிஸ் 5 கேட்டகரி, சூப்பர் ஸ்பெஷாலிட்டி ஆக்டிவிட்டி, அது எல்லா ஸ்பெஷாலிட்டி அசோசியேஷனை கம்பைன் பண்ணி மீட்டிங் கண்டக்ட் பண்ணுறது. அது மாதிரி நம்ம சூப்பர் ஸ்பெஷாலிட்டியில் மைக்ரோ லெவலில் பேசுகிறப்ப சம் செக்மெண்ட் மட்டும்தான் அதில் ஹெல்ப்ஃபுல்லாக இருப்பாங்க. இப்போ ரூரல் சர்ஜன் இருப்பாங்க, ப்ராக்டிசிங் சர்ஜன் அவங்களுக்கு மாலிகுலர் லெவல்லையோ மைக்ரோ லெவல்லையோ டிஸ்கஷன் யூஸ்ஃபுல்லாக இருக்காது. அவங்க வந்து காமனாக அவங்களுக்கு என்ன ப்ராக்டிஸ் பண்ணுறாங்களோ அந்த ப்ராக்டிஸை நம்ம கான்சென்ட்ரேட் பண்ணோம். அதுக்காக ரூரல் சர்ஜனுக்கு ஒரு செக்மெண்ட்டை வச்சு நாங்கள் பண்ண ஆரம்பிச்சிருக்கோம். அதே மாதிரி பிஜி கிளினிக், யூஜி கிளினிக், அதே மாதிரி ஜேர்னல் கிளப். ஜேர்னல் இப்போ எல்லாத்துலேயும் பேசிக்கிட்டு இருக்கப்ப அதை ஃபஸ்ட்டு முடித்தது அலெக்ஸ் சார் தான். ஜேர்னல் கிளப்னு சொன்ன உடனே அடுத்த நாள் ஜேர்னல் கொண்டு வந்துட்டார். திருநெல்வேலி வந்து உங்கள் டீம் வந்து அந்த ஜேர்னல் கிளப்பை வந்து அலெக்ஸ் சார் தலைமையில் நீங்கள் நல்லா குவாலிட்டியாக நாட் ஓன்லி ஆப்ரேட்டிவ் பிக்சர்ஸ், உங்களுடைய கிளினிக்கல் ப்ரெசன்டேஷன், சம் பேப்பர் ப்ரெசன்டேஷன் எல்லாம் வச்சு அந்த ஜேர்னல் கிளப்பை ஸ்ட்ராங்காக கொண்டு வாங்க. எவ்ரி 3 months அலெக்ஸ் சார் அதை நல்லபடியாக பண்ணிடுவார். அவருக்கு ஹெல்ப் பண்ணுங்கள். அதுபோல் உங்களுக்கு சர்ஜிக்கல் ஆங்காலஜிஸ்ட் சுந்தரம் சார் இருக்கார். அவர் இஸ் ஏ பெஸ்ட் சர்ஜன் அண்டு நல்ல டீச்சர். அவரையும் நீங்கள் யூட்டிலைஸ் பண்ணிங்க. அதனால் நீங்கள் வந்து திருநெல்வேலி பிஜிஸ் வந்து டீச்சரில் வந்து நல்லா ஐ விஷ் ஆல் பிஜிஸ் டு கெட் கிரேட் அக்கேஷன் அண்ட் ப்ராஸ்பரஸ் லைஃப். அது மாதிரி டீன் சார், டீன் வந்து இப்போ அலெக்ஸ் எவ்வளோ பெரிய இன்ஃப்ராஸ்ட்ரக்சர் எம்எம்சிக்கு ஈக்குவலாக இருக்குது, ப்ரைவேட் ஹாஸ்பிட்டல் காலம் நல்லா இருக்குன்னு சொல்கிறாருன்னா உங்களுடைய கோஆப்ரேஷன் இல்லாமல் நடக்காது சார். அது மாதிரி மெடிக்கல் சூப்பரண்டன்ட் அவருடைய, அது மாதிரி இங்கே மோகன் பிரசாத் சார், அவர் வந்து கிரேட் டீச்சர். ஆங்காலஜிக்கு யாரும் ஸ்பெல்லிங் தெரியாதப்பே அவர் வந்து ஆங்காலஜியை கரைச்சி சவுத் தமிழ்நாட்டிலேயே ஃபஸ்ட்டு முடிச்சுட்டு வந்து, நான் அவருடைய ஸ்டூடெண்ட், எம்பிபிஎஸ் நான் அவர் ஸ்டூடெண்ட்டு, எம்எஸ் அவர் ஸ்டூடெண்ட்டு, நானும் ஒரு ஆங்காலஜிஸ்டாக வந்திருக்கேன்னா அவருடைய சாருடைய இன்ஸ்பிரேஷன், அவருடைய ஸ்டைல் எல்லாம் அஃபெக்ஷன் ஆனதுனால தான் நாங்கள் வந்திருக்கோம். அது மாதிரி ராசகர் சார் கிரேட் பர்சனாலிட்டி. இந்த வருஷம் எண்டில் வந்து நம்ம ஏஐசி வந்து ஒரு நல்ல சிக்னிமெண்ட் ரோல் பண்ணோம். அதுக்கு முக்கிய காரணம் அவர் தான். அது மாதிரி கண்ணன் சார், கண்ணன் வந்து ஒரு இப்போ என்கிட்ட பேசிக்கிட்டு கூட கண்ணன் சார் சொல்கிறாரு, நான் திருநெல்வேலி கன்னியாகுமரியில் அங்கே டீனாக இருக்கேன். கன்னியாகுமரி டிஸ்ட்ரிக்டில் இருக்க ப்ரைவேட் மெடிக்கல் காலேஜில் டீனாக இருக்கேன். பட் எங்கள் பிஜியை வந்து அகாடமிக்காக முன்னால் கொண்டு வரணும். எல்லா ஏஎஸ்ஐ ஆக்டிவிட்டீஸையும் நீங்கள் எனக்கு வாட்ஸ்அப் அனுப்புங்க. அப்படி போகிறாங்களா இல்லையா நான் மானிட்டர் பண்ணணும். அந்தளவுக்கு ஒரு டீன் வந்து ஸ்டூடெண்ட் மேலே இன்ட்ரெஸ்ட் காட்டி வர்றவர் அந்த கண்ணன் சாருக்கு என்னுடைய வாழ்த்துக்களை தெரிவித்துக் கொள்கின்றேன். அது மாதிரி முத்துகிருஷ்ணன் சார் சீனியர் பர்சன், அவர் வந்து நான் எக்ஸாம் எம்எஸ் படிக்கிறப்ப எனக்கு எக்ஸாம்லாம் இருந்தார். அவருக்கு ஞாபகம் இருக்கா இல்லைன்னு தெரியல. நீங்கள் தான் எனக்கு பாஸ் கொடுத்துட்டீங்க சார். அது மாதிரி தங்கராஜ் சார், அவருடைய பேரில் தான் அந்த ஹால் இருக்குது. நான் கோயில்பேட்டையில் கொஞ்ச நாள் ப்ராக்டிஸ் பண்ணேன். அப்போ சாருடைய கேஸுக்கு நான் அசிஸ்ட் பண்ண போயிருக்கேன். அதுக்கு ஞாபகம் இருக்கா இல்லையான்னு தெரியல. இஸ் ஏ கிரேட் பர்சனாலிட்டி. அவருக்கு என்னுடைய வாழ்த்துக்களை தெரிவித்துக் கொள்கின்றேன். மேலும் இங்கே பல சீனியர் ப்ரொஃபஸர்ஸ், ஸ்டூடெண்ட் எல்லாத்துக்கும் என்னுடைய வாழ்த்துக்களை தெரிவித்துக் கொள்கிறேன். நன்றி, வணக்கம்.
Thank you very much, sir. I now invite Dr. BKC Mohan Prasad, sir, past chairman, TNSI, to render the felicitations.
காலத்தின் அருமை கருதி நான் சிறிது சுருக்கமாக முடித்துக் கொள்ள விரும்புகின்றேன். மேடையில் வீட்டிற்கும் பெரியவர்களே, இங்கு வந்திருக்கும் நண்பர்களே, மாணவர்களே, பெரியோர்களே, பாலமுருகன் சொல்லிட்டு இருந்தார். அதில் சில அடிஷன்ஸ் மட்டும். ஜெயலலிதா சாரை பற்றி நல்ல மிக்சிங் மேன் எல்லாத்தையும் சொல்லி சொன்னார். அவருடைய பேச்சை வந்து நாங்கள் என்ன யூஸ்வலாக சொல்கிறோம்னா இடி முழக்கம் அப்படின்னு சொல்கிறோம். நாங்கள் ஒரு மீட்டிங் நுழைஞ்சிட்டு இருக்கோம்னா இடி முழக்கம் முடிஞ்சிருச்சா நான் முடியலையான்னு கேட்போம். இல்லை இல்லை அடுத்து வரப்போகுது அப்படின்னா இடி முழக்கம்னா அது எந்த வேலையாக இருக்கட்டும், அது வந்து பேசுகிறவங்க பெரிய பேச்சாளாக இருக்கட்டும், டாக்டராக இருக்கட்டும், அரசியல்வாதியாக இருக்கட்டும், எதுவாக இருந்தாலும் ஜெயலலிதா சாருக்கு முன்னாடி பேசுறதா நல்லது. ஜெயலலிதா பேசுறதுக்கு அப்புறம் பேசினோம்னா அது கொஞ்சம் கஷ்டம். அது எடுபடாது. முக்கியமானது அது யோசிச்சு நீங்க பண்ணிக்க நல்லது. ஏன்னா அவர் பேசினவர் மித்தவருடைய பேச்சு எரிபடாது. அது வந்து ரொம்ப ரொம்ப முக்கியம். அந்த திருநெல்வேலியை பற்றி பாலவன் சொல்லிட்டு இருந்தாரு. அடுத்து டீன், அது வந்து ரொம்ப கரெக்டான வேர்டு. நீ என்னதான் ப்ரொஃபஸர் ஆக்டிவாக இருந்தாலும், ஹெச்ஓடி ஆக்டிவாக இருந்தாலும், டீனுடைய என்னதான் அனுமார் வேலை பார்த்தாலும் பெருமாள் வந்து பெர்மிஷன் கொடுக்காட்டி ஒன்றும் செய்ய முடியாது. அதனால ஒரு நல்ல டீன் உங்களுக்கு கிடைச்சிருக்காருங்கிறது ரொம்ப ரொம்ப முக்கியம் இந்த மாதிரி அச்சீவ்மெண்ட் பண்ணுறதுக்கு. இன்னொன்று வந்து நான் என்ன சொல்ல விரும்புகிறேன்னா, ஒரு களிமண் எடுத்துக்கிட்டு அது கிடைக்கிறோட கையில் பொறுத்து தான் அது குரங்கா மாற போதா, அது விநாயகரை வாங்க போகிறாங்கிறது இருக்குது. அது போல் வந்து அரசு பணியில் வந்து நம்ம இன்ட்ரெஸ்ட் பண்ண என்ன வேணாலும் செய்யலாம். இன்றைக்கி சூழ்நிலை வந்து சிஎம்சிஸ் ஃபண்ட் இருக்கு. இந்த மாதிரி நம்ம ரவிச்சந்திரன் சார் மாதிரி நல்ல டீன்கள் வராங்க, நல்ல பாலசுவனி மாதிரி நல்ல மெடிக்கல் ஸ்டூடெண்ட் கிடைக்கிறாங்க. அப்படிங்கிறது என்ன பண்ணலாம். பட் அதுக்கு வேண்ட இன்ட்ரெஸ்ட் வேணும். அதுக்கு வந்து என் கிளாஸ்மேட்ஸ் பிரதாப் ஞானமுத்து மாதிரி, எங்களோட வாத்தியார் முத்துகிருஷ்ணன் சார் மாதிரி, இஸ்மாயில் மாதிரி நல்லவங்கெல்லாம் வந்து டொனேட் பண்ணி இந்த மாதிரி ஸ்கில் ஆளுகளும் வேணும். அதை நினைச்ச என்னவோ தான் நான் வந்து அரசு பணியை வந்து இன்னும் 1 வருஷத்துக்கு இந்த அரசு வந்து நீட்டிச்சிருக்கு நான் நினைக்கிறேன். ஏன்னா இன்னும் அலெக்ஸ் மாதிரி ஆளுங்க இன்னும் இந்த சர்வீஸை வந்து இன்னும் 1 வருஷத்துக்கு எக்ஸ்ட்ராவா செய்யணுங்கிறது வந்து ரொம்ப அரசு பணியில் இந்த மாதிரி சில பேர் சொல்றாங்க இளைஞர்களுக்கு வாய்ப்பு கிடைக்கவில்லை அதனால சொல்றாங்க. பட் இருந்தால் கூட இந்த மாதிரி நல்லவர்களுக்கு இன்னும் ஒரு நற்பணி செய்வதற்கு வாய்ப்பு கிடைக்கும் பொழுது இன்னும் இந்த டிபார்ட்மெண்ட் முன்னேறும். நான் என்னோட பெர்சனல் ஒரு எக்ஸ்பீரியன்ஸ் சொல்ல வரும்போது, ஒரு பேஷண்ட் இருக்காங்க, சீக்கிரம் ஆப்ரேட் பண்ண பேஷண்ட். அவர் ஒரு நாள் வந்து திடீர்னு வந்தார், எல்லாம் பார்த்துட்டு இருப்பேன், சார் எல்லாம் ஒய்ஃபெல்லாம் நல்லா இருக்கும், இல்லை சார் ஒரே ஒரு ஆப்ளிகேஷன் என் பையனுக்கு வந்து திருநெல்வேலி எடுத்துருக்கு, எப்படியாவது இருந்தேன் சார் அலெக்ஸ் யூனிட்டில் மட்டும் எனக்கு அவனுக்கு பிஜி சேர்த்து விட்டுறணும் அப்படின்னு சொன்னார். என்ன எப்படின்னு சொன்னேன், என்ன சார் அது எல்லாமே லேப்ராஸ்கோ, அதாவது ஓப்பன் சர்ஜரி, லேப்ராஸ்கோபிக் சர்ஜரி, இந்த மாதிரி டீச்சிங் ஸ்கில்ஸு எல்லாமே பெஸ்ட்டாக இருக்கிற யூனிட்னா அது டாக்டர் அலெக்ஸ் யூனிட். ஒன்றுமே இல்லை, என் தம்பி தான் நான் சொல்லி சேர்த்து வரேன்னு சொல்லியிருந்தேன். அந்த அளவுக்கு பாலவன் சொன்ன மாதிரி இந்த முதுநிலை பட்டப்படிப்பு மேற்கொள்ள நம்ம ட்ரெயின் பண்ணுற விதம் தான் அவங்களுடைய மனதில் விதைக்கக்கூடிய விதை. இந்த விதை வந்து சரியாக இருந்தால் தான் நீங்கள் பின்னுக்கு நன்றாக வளர்ந்து நல்ல மரமாக வளர முடியும் என்று கூறி இவங்களுடைய பணி தொடரும் என்று இறைவனை வேண்டி நல்வாய்ப்புக்கு நன்றி கூறி விடைபெறுகிறேன். வணக்கம்.
Thank you very much, sir. I now request Professor Dr. Jailal sir, National President, Indian Medical Association, to deliver his felicitations.
Beloved and distinguished Dean of this medical college, Professor Dr. Ravichandran sir, the distinguished President, Chairman of the Association of Surgeons of India, Tamil Nadu, and my senior colleague in post-graduation, Dr. Rajashekar, the நம்ம நிரந்தர முதல்வர் மாதிரி நிரந்தர சர்ஜரியினுடைய HOD, one of my very beloved brother, Dr. Alex, a leader for excellence in both in ASI and the Indian Medical Association, and the very oncologist, Dr. Balamurugan, the medical superintendent Balasubramaniam, and the distinguished professors of Department of Surgery, and my beloved and distinguished teachers and my dear students. I am extremely delighted to be here at this moment to represent our Department of Surgery, and knowing that the applause and the appraisals and the praises which you are bestowing upon our Department of Surgery HOD, Dr. Alex. He deserves all this appreciation, all this applaud because of his committed and sincere work. I have been seen in many organizations, I have been with many associations, but the amount of the love, affection, family, respect, unity, which you can never see in any other department in any other college. And the way in which this function was organized, it is every PG has felt that this is their family function. And the way in which that they were motivated, they were guided to do the things, they were, it is something amazing to see, which we can never see in medical college set up in a private medical college or in a government medical college. Here it is not out of compulsion, but out of choice. It is not out of the force, but out of love. And that unity is being maintained. That can be possible only by a leader for excellence. So we in the Department of Surgery, every one of us are today feel proud, privileged, and to work under the captain of Dr. Alex, and he deserves an honor appreciation. And I salute him for all the good things he is doing. We also salute our Dean for the fabulous support, encouragement he is giving. Today is a special day for the people like us. Though we are in the position in a top level in Indian Medical Association, but today I am much humbled in front of my beloved teachers. That is a great honor for anyone to be in the top and see and come and see the blessings of our own teachers who taught the basics and not only the surgical skills, but the skills of the life, the skills, attitude, the involvement, the altruism, the passion, and everything has been bestowed on us. And as a student of Tirunelveli Medical College in undergraduate, I can say that you are also fortunate that here is one medical college, we are not only teaching cognitive skill, we also teach the affective domain and the psychomotor skill. That is a privilege of this institution. And it is also very specific. Such a amount of the senior professors are able to visit this institution very often, and the department is always recognizing their contribution. And what a great tribute to Dr. Tangaraj, Professor Tangaraj. And if today we all are remembering his passionate work and love and affection which he has shown to his postgraduate and colleagues, and today if this hall is dedicated in his name, that tells the tribute to the real teacher par excellence. So it is a great honor for every student of this college and every professor of this college. It is a great privilege, and one of our senior professor is being honored with a great privilege to entire block is named after him. And a hall is named under another veteran lead professors, Professor Pradap Jnanamuthu and Professor Gobinathan sir. The amount of sacrifice they did and the involvement in altruistic skills in which they have served this institution is a telling sign today that it is been going to be accepted as a skill lab. And it is not only that you are going to enter into that skill lab, but you are entering into it is like a sanctum sanctorium where all the blessings and the highest blessings of these great souls are going to be with us. So anyone who is entering into this hall, I know for sure, is you are not going to get only your skill there, and you are going to be blessed by a marvelous blessing and which these honored professors are going to accept to you. And that is a great achievement today. I hope there is no press people, if otherwise they will put the paper today. Jailal opposing mixopathy and he is an expert in mixing. Balamurugan sir, unnecessarily you have brought in this message. I am dead against this mixing concept of that. I am one of the teachers who is passionate in teaching with very minute details of surgery. And after hearing this report, after hearing this notification of the CCIM, which says with 2 years of just training with 39 procedures, you will get a Master of Surgery degree. And what is the great fun in having such a 3 years of grilled work, a training, such a postgraduate, excessive classes and skill lab, when your colleagues will come there, only 39 procedures and no hernia even, but cholecystectomy is there. And they will do, and they will be also coming as a Master of Surgery course. And that is the reason which infuriated me, and it has anguished us. The encroachment of these people into the field of general surgery that promoted a great fight. We organized a fight across the country for the 14 days of the fasting and massive representation. And I'm so fortunate today. I'm so happy to inform to this audience. When yesterday we had an extensive discussions with both our Honorable Health Secretary and Ayush Secretary. They in principle agreed what they had done for introducing the MS General Surgery is absolutely wrong, and the process they have initiated. The 17th, I'm again meeting the Nidhi Ayog, and the meeting is called for that. I am confident today with the entire support of our medical profession and the support of our fraternity, we will be able to stop this encroachment, stop this onslaught into the medical profession onto that. And that is going to be a great day for us. And our aim, we are not against any system of medicine, but believe we are calling for a purity of the system to be maintained, and the purity of the profession has to be maintained. So the things are going in the right way, and I am confident that we will be able to win over the crisis. I am also happy to inform to you, the medical students, with the postgraduate, there is an absolute change in the paradigm of the examination pattern of the super speciality has been introduced by the National Board of Examination. Now it is an comprehensive examination. You are not going to write only what the subject you want to learn. If you want to do vascular surgery or oncology, previously it is enough you read on the oncology and you can go and appear for the examination. Now the questions will be from comprehensive. You need to appear for the same examination whether you are asking for an MCH oncology or MCS vascular surgery. So this is another big challenge for the postgraduate, that you need to study little more aggressively, little more in-depth study is mandatory required. And every time when the MCH marks are coming, there will be, we also make an appeal, and then the marks, cut-off marks will be reduced. But this time the National Board was very particular, the NMC also particular, they have reduced 5 marks, but now though there is a 720 MCH seat are vacant, but the NMC has refused to reduce the mark still further. Last year it has happened. So again it is a big challenge for you. Unless you are going to get qualified, you will not be able to get, because now in the administration, the quality and the sincerity of the students is going to be a more important area. So there is a very important time for the postgraduate to have concentration more on your studies. National Board also starting a 2-year diploma course in diploma in surgery, which we opposed, and now it is put on hold. In the moment of this, when Ayurveda is starting the 2-year course, The national board itself is starting a 2-year MS course. Is not an appreciable one, not is a good thing to go ahead. But then another proposal of the national board is to start an MCH general surgery. That is what they are going to start, a 6-year course of the general surgery itself. And instead of going to then an MCH to then another field, that you will be able to come to a particular field, and there this course may come within another 2-3 years. The process is on, and we want to restore the general surgery principle, general surgeon, instead of that making the super speciality as a main area. One of the things the government now today feel, the major drawback which has happened in our modern medicine is we have gone for a super specialization and made that, and we are not able to make a comprehensive knowledge is not able to given to the medical students. If a young graduate who is coming out of a medical college as an MBBS, he is not competent enough to even write a prescription for hypertension. This is exactly the word what the health secretary was saying. You just finish a person coming out of the medical college, you ask him to write a prescription for a hypertension, and he is not able to do that because you people or you super specialists and specialists think that MBBS is nothing, so you want to always take the field to the particular specialty. And this is a mindset now in the whole administration. That is why even the examination pattern is now changed for the MCH, MS general surgery, and you need to be a comprehensive general surgeon first before entering into the super specialty surgeon of that. So that is a great opportunity for us to go ahead. Another thing, as a surgeon in the top level, and I was able to introduce then the NTB program, which the government, when we talk often, they always talk about pulmonary TB, but one of the major problem we face is an extrapulmonary abdominal tuberculosis and other tuberculosis. Now the government has agreed upon to include and the extrapulmonary TB. And when we talk about TB, we are not going to talk only about the pulmonary TB, and even surgeon has a great role to play in the elimination of the NTB program in this country. And all this is possible only because that we are able to project our views and project our themes and our visions in an appropriate way. That is a lesson I just want to admire to all my dear colleagues. And many of you, many of my colleagues and many of my seniors also, how do you find time? And I always say, and if you have a belief in you, and if you have a belief in your team, and more so if you have belief in your card, everything is possible. And I also appeal to my students, believe yourself, believe your team and your teachers and colleagues, and also more so, believe in your God. God will definitely bless us and empower us. I wish all the best for my postgraduate. I love them so much, and thank you very much for this wonderful department in which God has given us opportunity to serve.
Thank you very much, sir. It is said that the best teachers teach from the heart and not just from the books. So, it is time for us now to show our love and gratitude by honoring the veteran and senior surgeons. I now request Dr. BKC Mohan Prasad, sir, to honor Dr. Govani Nayagam, sir. I now request Dr. Jailal, sir, to honor Dr. Pratap Jnanamuthu, sir. I now request Dr. Rajeshekar, sir, to honor Dr. Muthu Krishnan, sir. I now request Dr. Balamurugan, sir, to honor Dr. Ismail, sir. I now request Dr. Rajashekar sir to honor Dr. Gopinathan sir. I now request our beloved Dean sir to honor Dr. Balaji sir. I now request Dr. Alexa to honor Dr. Tangaya sir. I now request Dr. Kannan sir to honor Dr. Chidambaram sir. I now request Dr. Jailal sir to honor Dr. Parimalam ma'am. I now request Dr. Rajashekar sir to honor Dr. Danu Krishnan sir. I now request Dr. Balamurugan sir to honor Dr. Maheshwari ma'am. I now request Dr. Ravichandran sir to honor Dr. Pandi sir. I now request Dr. Kannan sir to honor Dr. Sulaiman sir. I now request Dr. Kannan sir to honor Dr. Varadarajan sir. It is an honor to have two classmates on stage sharing the honors. Thank you, sirs. It's now time to felicitate the head of the departments. I now call upon head of the department, Dr. Alex Arthur Edwards, sir, to honor Dr. Amuda Rani ma'am, head of the department, Department of Anesthesiology. I now request Dr. Alex sir to honor Dr. Chendil Sivamurthy sir, head of the department, Department of Plastic Surgery. Dr. Chendil Sivamurthy sir is the son of our very respectable Professor Dr. Tangaraj sir, in whose name this seminar hall is being opened. We are very happy to have you, sir. I would like to invite Dr. Ramasubramaniam sir, head of the department, Department of Nephrology. I request Dr. Alex sir to honor Dr. Ramasubramaniam sir. I now request Dr. Jailal sir to honor Dr. Sulaiman sir. Thank you, esteemed guests. It's now time for us to award the medals and the certificate of appreciation to the meritorious students. I now request our beloved Dean sir to hand over the medals and the certificate of appreciation to the following students. General Surgery Gold Medal for the year 2019 goes to Dr. Dinesh Kumar sir. The gold medal for the year 2019 is being sponsored by Dr. Parimalam ma'am. I request ma'am to join the stage. Thank you, ma'am. Ma'am, please stay back with us, ma'am. The General Surgery Gold Medal for the year 2020 has been awarded to Dr. John Nixon. This is also sponsored by Dr. Parimalam, ma'am. Thank you, ma'am. It's now time for the silver medal winners. The silver medal for the General Surgery Department has been sponsored by Dr. Gobinathan, sir. Sir, please join with us, sir. General Surgery Silver Medal for the year 2019 has been awarded to Dr. Raghuram A. The General Surgery Silver Medal for the year 2020 has been awarded to Dr. Arun Raja KK. Thank you, sir. Finally, we have the Certificate of Merit. I request our Dean sir to give away the Certificate of Merits. For the year 2019, Certificate of Merit goes to Dr. Mahadev, sir. The Certificate of Merit for the year 2020 has been awarded to Dr. Sendil Kumar. Thank you, esteemed guests. We would like to thank the sponsors and the pillars of support who have been through us for the renovation and for the inauguration of all the labs and the library. So we thank our Dean sir, Vice Principal sir for their constant support and guidance throughout these endeavors. Then we thank Dr. Kannan sir for his constant encouragement and his support which he has been bestowed us during his period when he was there, when we have obtained this block for the Department of General Surgery. Then we thank Dr. Nirmal sir, Dr. Karthiyani ma'am and Dr. Shivana Pandian sir, associate professors who have been a major sponsor contribution towards the development of the seminar hall. And we thank the PWD contractor, Mr. Ramesh, and the PWD engineer, Mr. Rahul, for their efforts and for the beautiful renovation which they have done for us. And along with them, the main credit and thank you should be given to the Halstadians batch. They are our seniors who had contributed towards the renovation of the department. We really appreciate them and thank them for their love and support towards the department. So I request Dr. KK, I request the members of the batch, Halstadians batch, those who are available, please come onto the stage. Dr. KK Arun Raja sir, Dr. Preeti, Dr. Nixon, Dr. Sendil sir, Dr. Nagavishnu, Dr. Karthigeyan. They are just a representative of the 20 batch of Halstadians. Thank you, sirs. I now request Head of the Department of General Surgery, to render the vote of thanks.
Praise God. Again, I am very much delighted to be here to deliver the vote of thanks. So in fact, everything was told my PG. I think the notes written for me, she read everything. So that's what happened when you take class also. So she has delivered the vote of thanks address. But anyhow, I am very hungry and hope you are all hungry. So it's mutton biryani is ready. So the washroom is ready this side, and you can have a sumptuous lunch, and you can bless us and leave and bless all our children. So we are going for the examination, probably the 15th of May this month. And I thank all the organizers of this event. I thank profusely our Dean, who is given all the freedom to work, and whatever budget we make, he will sanction everything, and through the insurance scheme. I think Dr. Sivagami is here. She's here, gone. So Dr. Suresh Kumar and Dr. Sivagami were behind the scene. And I would like to thank our Vice Principal, always behind the scene. You know, he was till here, and after that he left. So he was the one who planned everything. You saw the faculty room, you saw the library, everything was designed by Shandaram sir. You know, when you are interested, he will come and he will do everything for us. And big thanks to our Vice Principal and the man of action, our MS sir, Bala sir, my close friend. And this is a team of Dean and Medical Superintendent. And I thank our Chairman Dr. Rajeshekaran, and more thanks to Madam, who has come all the way from Salem. During the installation ceremony, we were there in Salem as a team from Tirunelveli, and she was very active, and the hospitality were exemplary. And thank you, Madam, for accompanying sir. The big thanks to you. Hey, Madam, ஒரு shawl போடணும். Later.
Ma'am, please join us, ma'am.
Babita.
I request Dr. Babita ma'am to honor.
Kamalin irukanga? Kamalin, Irene madam. Babita, ஒரே நிமிஷம். Irene. Thank you so much, madam. And I thank Balamurugan sir. You know, Rajeshekar sir told he's a ringmaster. You know, every now and then, 11 o'clock, 12 o'clock, he will put a message and call what I have done. Your target is not achieved. You have to do say things. Otherwise, you give the list to me. I will contact like that. So, and you cannot sleep or you cannot take rest. You know, the man behind the complete ASI. So, thank you, sir. Thank you, sir, for. He was not feeling well. Even then, when we asked him to give a lecture, Gladly he told that he will come and participate. Thank you very much, sir. And my teacher, Dr. BKC Mohan Prasad, I was working in his hospital for about 3 months to 6 months when I was doing after house agency. I learned a lot of techniques from sir. He is my teacher, and every function, the inauguration of our department, seminar, ASA meeting and all, he is the first person we contact. Immediately he will accept and he will come all the way. He will be here throughout, and he is a great blessing for us, sir. And Tamil Nadu ASA is proud of you, and the Department of General Surgery and Tirunelveli Medical College. So we warmly thank you and welcome for all the good things you have done to us. And I thank our chairman, Kannan sir. Now he is the one who is organizing Man Began this hall. It was belonging, Dr. Ramasubramanian was, when he vacated this place to PMSSI, this hall was given to us only by Dr. Kannan, sir. So he gave us permission and we occupied that. And I thank and sincerely for the batch, the 20 students. So this costs about 8.5 lakhs. So we, some of our faculty and the remaining entirely, I think they spend about 30 to 35,000 from their pockets. Voluntarily they donated, and we could able to do that with the help of coordination from Dr. Nirmal. And I would like to mention Dr. Nirmal, Dr. Vinod Kumar, Dr. Ramalan, and Sivanu Vandian is missing. And those are our pillars of this department. Even though they are outside Tirunelveli, they think that this is their homeland. So I thank all the pillars of the Tirunelveli, and ASA members, sir, Ibrahim sir has come, and so many ASA members have come, and I thank you all for that. And big thanks to all the professors, my teachers, Govindayam sir, Gobinath sir, and Parimala madam, my unit chief, and Chidambaram sir, my teacher, and Ismail sir, Pranab sir, the veterans, Angara Thanakrishan sir, Tangaya sir, apro Mageshwar madam கூட நான் work பண்ணிருக்கேன், Sulaiman sir, my elder brother from whom I took charge, Dr. Varadarajan sir. I cannot forget him, he was very enthusiastic, and he was my mentor, and I learned a lot of things from him. How to have an administration, everything he used to tell. And thank you, Anna, for your participation. And I thank all my, the supporting, my staff. We call it a surgical family. It's not a department, it is a family. We have got all male and female members, we have got a lot of coordination, and all the faculty members are very, very good, very cordial. They are very enthusiastic in their activities, and all male and female faculty members. And moreover, this function was organized by the exam going batch. So please stand up. So we'll have to give them a big standing ovation. By the time they leave the hall, it was about 5:30 in the morning. They did all the decoration, especially the girls. They did all the good works, and very big thanks and very big claps to all of you. This is a team which organized this function. Vignesh, all of you come front. Annie. And I thank Dr. Sindhi, Kavida. They have Kavida phoned only. I invited. I didn't invite you personally. And thank you for coming along with Karthikayani madam. And Sendil Somuthu sir and Karthikayani madam were children of Dr. Tangaraj. So we are happy that Tangaraj sir was my teacher. When I joined post-graduation, he was my teacher. He was my examiner. I failed in the first attempt. Yeah, Kannan sir also failed in the first attempt. So I wish all the exam going batch students, we have all failed. So never bother about the failure. Right.
What do you want to convey to them? Don't bother about the result.
So I wish you all the success and all getting through, because nowadays it's very difficult to fail a candidate. So it's a big batch. All guys are very enthusiastic. They did all the groundwork. They mobilized so many things, including the decoration and hall arrangements and the food, sound system, everything they have arranged. So in fact, we didn't do any effort. We just organized, and with the help of Dr. Nirmal. Nirmal, please get up. Vinod Kumar sir, Amalan, and Sivanu is missing. Karthikeyan madam, Irene. And my senior colleagues like Dr. Nagalakshmi, he is getting promoted as associate professor. Inge Rajkumar, and Betsy. Advance congratulations to 3 of our assistant professors promoted as associate professors. Please come. Vinod Kumar sir, Vinod Kumar Chuliachi. Vinod Kumar Elundarana Mela, balloon tattoo. Thank you so much, and all the family members. We had a very good time in Kuttalam, and thank you so much for all your participation. And I thank the students from other medical colleges. Thoothukudi Medical College, please stand up. Thoothukudi Medical College students, right? Thank you so much. So I thank the PWD. AE Rahul is here. Ramesh will give a small memento. Ramesh is hard to good. I request our chairman to give a small memento to our PWD contractor. I invite Dr. Karthikeyan. We will give a small memento to Karthikeyan, the 19th batch. So if I miss anybody, please forgive me once again, and thank you all for all your, and the live streaming. Dinagar, please. So we will give a small memento to Mr. Dinagar by our chairman. Thank you so much, sir. Thank you, sir. And once again, I thank you all. And now the lunch is ready. Please. Okay. So after this, we'll go for a lunch, which is arranged in our examination hall, which was created by my elder brother Varadarajan sir. So the lunch is ready. Just before going that, Buthakrishnan sir is there in our department. Just we will cut a ribbon and we will go to the lunch. Thank you so much, and once again, and wish you all the best, and see you again soon. Thank you so much.
Thank you, sir. I request all the esteemed guests to have the lunch and join the session in the afternoon. Please wait back for the national anthem. Please wait back for the national anthem.
अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल बंगा विंध्य हिमाचल यमुना गंगा उज्जल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे.
Thank you one and all. All are invited to the department for the inauguration of the library by Professor Muthukrishnan sir.
Well done, ma'am.